just going to wait for one. Oh, we'll take you here. Great. Well, welcome, everyone. We've got, given it's a pretty busy event that we're in the middle of, various people are coming in and going out, so there'll be a bit of movement during the meeting. But fabulous to see so many of the leadership team here. Just by way of welcome and introductions, we're delighted to welcome Healthwatch as a new member of the National Information Board. So Gerard is joining. Unfortunately, Catherine Rake isn't here, but that's great. And we will shortly be joined by Susanna Fox, who's a great friend and is also the Chief Technology Officer of the Health and Human Science Services Department in Washington, D.C., and has been doing a fantastic job of rallying federally, rallying enthusiasm around open data technology. So she's going to join us just to observe, and we'll welcome her during the course of the meeting. So if I can just take everyone to the minutes of the last meeting, and if anybody has any particular issues, perhaps they could raise them now, otherwise we'll take those as read. Just to say that, as usual for the leadership meeting, we are all collectively committed to working as transparently, as openly as possible, given the nature of the agenda itself. So this is a live-streamed meeting, and you can see the various cameras around the room. So just to remind people of that. In terms of the structure of today, we will be having our meeting, and at about 11 o'clock we're going to have the important discussion about where the framework has got to, implementation plans around that, and also just to reflect on some really important deliverables. I'll come to those in a minute. But after the sort of formalities of this meeting, we're then going to move into a public session where members of the public will be invited to ask questions of us, and many have already actually offered their thoughts via Twitter and other social media. And very kindly, Joe Bibby, Director of Strategy at the Health Foundation and one of our independent members, is going to chair that conversation. We were trying to get the model for this right. How do we authentically invite people, to raise questions and have engagement with the National Information Board. So that will be happening afterwards. And then following that, Una is going to be chairing a panel of members out on the plenary stage, which I think everyone would be very welcome to attend. So just those formalities over. Assume the minutes are taken on. I'm now going to move into Chair's overview. So I know some of you only just landed today, but for others who've been at Expo, I really hope you had a good day yesterday. I've got to say, I love this. I love Expo. It's second year, really. We've done it, and there are nearly 6,000 people going to be here today, and they are really the people on the front line of services in local health and social care economies, trying to do their best to transform services for patients. And the energy is just brilliant. Passion, the commitments. I gave a small talk earlier this morning, but for those who didn't hear it, I had the great privilege of hosting the Obesity Challenge Awards, which we've done with the US. And on both sides of the Atlantic, we've released a certain amount of kind of open data on obesity prevalence, which is comparable between the US and the UK for the first time. And so hundreds of apps developers put their best, creative energies to bear, and we've awarded several prizes, and the prize winners told their stories yesterday at this event. And Cancer Research UK just done a brilliant job on analysing all the data by constituency. And I have to say, I was really surprised that the city of Durham is the constituency with the highest proportion of its population obese and overweight. And I asked people in the audience this morning just what they thought that percentage was. But would it surprise you to know that 72.5% of people in the city of Durham are obese or overweight? It's just, and it's this kind of data sharing that will drive commissioners, providers, local health economies to understand the issues they're facing. And I'm sure that the city of Durham probably hasn't quite realised in a way that's now very accessible to them. That's the sort of challenge. So some really great energy around the place, but also I think a proper degree of kind of scepticism. We've launched today, as we'll hear a bit later on, a very important step forward on the road to paper-free at point of care. We've out there literally is a bonfire of faxes. If you go onto one of the stands, you can see sort of an illustration. But Of course, meanwhile, in the real world of the NHS, people are facing real constraint, real challenge. Sometimes the concept that the challenge is an opportunity misses people by just because of the sheer stress of delivering to their best ability. And so there's a kind of, we need to recognise that scepticism, that sense of pressure is one that we collectively, nationally and locally need to share and support. And we've been running over here, we, in April, became the first country in the world to offer online record access in general practice. We should be really proud of that achievement. All we've really done, though, is switch on the technical infrastructure, moving to a point where this really creates the culture change we want both in clinical practice and in the public is obviously a different journey. But I just wanted to read out this quote from a GP in Huddersfield who's been engaged in one of the early pilots we were running to just look at some of the operational impacts of online record access. And so he says, at first, I was quite nervous about the prospect of patients accessing information that they may not understand or that they may find upsetting. But this all changed when one of my diabetic patients signed up. Almost immediately, I could see a positive change. My patient started preparing ahead of his consultation by accessing his latest test results and comparing them to past results. This has meant the 10 minutes we get together is very productive. 10 months down the line, I'm even seeing this patient's controls are improving. And I just think that's great because everyone's on a journey, and I talked this morning about pace. We've got to be ambitious, but we've got to take everyone with us. We can't leave anybody behind. And I think that's a really important reflection, if you share it, that the National Information Board needs to support and deliver on. So, just to remind everyone, Rebecca's going to do this in more detail later, but story so far, we collectively should be very proud of the achievement we've made in terms of just achieving consensus around the priorities for data and technology. People have worked incredibly hard across the entire family of this movement, and I actually reflect that many of my colleagues who've been working on delivering some of the actual implementation plans, on delivering the broader delivery strategy for framework, are beginning to feel more that they're working to the collective business objective of patient outcomes than to particular loyalties to organisations. I just feel people are working fantastically well together, and I just want to say thank you for all the incredible hard work. But last November was a milestone. The framework was published, and since then, all this work has happened, and today we're going to learn about its progress. In the meantime, not only, of course, was the National Information Board set up by the Department of Health to provide it with strategic guidance on how best to put data and technology to work for patients and citizens, but the 5-year forward view has now built this group into a fundamental part of its own governance. So equally, the National Information Board is part of supporting delivery of the 5-year forward view, and that's a really important imperative that we need to bear in mind. At no point can we ever think of doing technology for technology's sake. This is about transforming general practice. It's about supporting the delivery of really improved acute services. It's about empowering patients. So that connection to the 5-year forward view is a very important one for us. In addition to just delivering on the framework, we have some other responsibilities. One is, as the Secretary of State asked us earlier this year, was to advise him on the shape of the transparency project that he's been leading, My NHS. Another is to publish an annual report which will survey the degree to which the NHS is indeed delivering on the framework's priorities, and today we're going to get an update on the prospectus, which is our first go at kind of describing what that report should be doing. Next March, if the board is agreeable with the outlines of the prospectus, we'll actually publish the first of the annual reports, which will reflect on progress. And in addition, the Secretary of State announced recently that Baroness Martha Lane Fox was going to work with the National Information Board on developing some very specific proposals for how we can take the whole community with us on this digital journey, the inclusion. So she will be working closely with her, and we're hoping very much that she'll be at the December meeting to update us on how she wants to take that work forward. So just before I finish and we get on with the actual meat of the meeting, I just wanted to say a few thanks. My first big thanks goes to Una. I mean, the National Information Board was Una's idea, and her support is invaluable. I think it's fantastic that you've had the time to chair the panel for us today. But here we have a great permanent secretary who is leading an agenda that has defeated this public service for a long time, and I think we're on the cusp of achieving something that has not been achieved before. So I just wanted to say that. I also just wanted to thank Claire Marks from the Strategic Clinical Reference Group, who's going to tell us about this fantastic app that Oxygen shortly, because, again, a really important part of getting this right is to get the clinical voice, not just in the room, but actually leading the conversation. And the Clinical Reference Group, as we know from the last meeting where they made that very imaginative set of proposals around making sure the technologies of delivery in clinical practice were available. Just wanted to thank Claire and Martin Severs for rallying the clinical voice into the room. And then finally, obviously, Jeremy's comments yesterday focused attention on the role of the National Data Guardian, and Fiona I'm absolutely delighted, is going to bring her authority to bear on solving this really serious global problem of kind of what are the rights people should have to opt out of data sharing. We're all agreed those rights are fundamental, they are a human imperative, and I'm delighted that Jeremy and Fiona are going to be driving that, or Fiona is going to be driving that forward. And I do think that the National Information Board must do everything it can to support the work of the National Data Guardian, so I just wanted to pay tribute there as well. So I'm going to stop at that point and move on, in fact, to Claire, who's going to give us an update, I think, on Oxygen. Oh, no, sorry. George. Forgive me. No, I'm not. We're going to start. Welcome, George Freeman, Minister for Life Sciences, but actually really Minister for the Digital Revolution. And so, George, to your keynote address. Thank you very much.
Well, thank you, Tim, very much. I've had some really underwhelming introductions, but that takes the biscuit. Fortunately, we share the passion, so I know how serious you are. It's a real pleasure to be here. I'm sorry I couldn't be here yesterday. Ministerial visits are tightly controlled, but I hope you will have seen from the clarity of what Jeremy, Secretary of State, set out yesterday and what I'm going to say today that there's been a lot of work gone on in the summer on this agenda to try, as a new government, to make sure that we set out very clearly the political leadership and the commitment, the legislative, regulatory and policy framework to really drive forward and create the cover. I mean that word in its best sense, the proper integrated political, legal, legislative cover to drive this forward and to give you, the people on the front line, the chance to really seize this prize, which we all know is so important. I wanted to echo Tim's comments, actually, about the pace, the buzz, the vision, the ambition. I just bumped into Susanna Fox on the train. I'm new into this portfolio and this brief, and I went to Datapalooza as my first visit. I was just bowled over by how in the American healthcare system, where digital and data is taken for granted, it's right in the vanguard of the revolution. They view us as laying so many of the foundations for this and aspiring to do something extraordinarily ambitious and noble and of global relevance. And I think it's just worth reminding ourselves that we labour under so many daily obstacles, challenges. This is the world's biggest healthcare system. It's not easy. If it was easy, we'd have done it years ago. But we shouldn't either underestimate the progress that we are making week in and month in. And a lot of that goes down to your organisations and the leadership you're showing. And I wanted to echo the thanks to Dame Fiona and Una and Bruce and the NIB as an organisation. I think it is genuinely really getting a grip of these issues and driving them through. And I know how hard many of those issues are. And it's great to be back. I think this is my third or fourth visit, and I'm determined to be the minister here for you and to make sure that if there are obstacles, we're clearing them. You all know in this room the potential and the prize. I am going to repeat it because I think part of my job as your minister and as a politician is to make sure that we communicate that vision. But I also want today to stress something that I think is absolutely key to us really moving from vision to practical reality, to transforming the experience of healthcare on the ground for the patients and the users for whom this magnificent service exists, and that is about relentless focus on patient benefit. We all know the system benefits, but that's not what excites people in the morning when they get up, and it's not what irritates people in the car park of hospitals. It's not what drives people wild trying to navigate the difficulties of our system. We've got to focus on tangible benefits for patients, and I think that will unlock public support and patient support and put wind in the sails of this noble endeavour. So I do want to talk about this as one of the great opportunities for UK leadership and NHS leadership in 21st century healthcare, harnessing the power of integrated data for health system, for individual care and for research. But I think there's something even more precious and powerful in there, which is a quiet revolution of patient empowerment, shifting healthcare from being essentially something in the 20th century that we did, the benign health service system did, to essentially passive patients, often all too patient, to a model of 21st century healthcare where we empower active healthcare citizens to take responsibility for their health and life choices, their outcomes, and to embrace those responsibilities and those opportunities. And the key to that is information. I think that is really the quiet revolution that this NIB is leading. And I hope that you can see from the announcements yesterday how committed the Secretary of State and I are to those principles he set out: intelligent transparency, patient empowerment, and to the bedrock on which it's all built of patient trust and confidentiality. Those of you who know me know I came into this from research. I'm not a clinician. I've had a 15-year career, been lucky enough to have a 15-year career in and out of NHS research leadership. And you don't have to be in that sector very long to realise that data is rapidly transforming the way we discover new medicines and the way research is carried out. But, of course, there are two other core pillars to the importance of data across our system: system performance, safety, quality of the fourth biggest organisation in the world, and individual care. Even if the first two don't inspire you, at some point all of us in our lives will go back into the NHS and need treatment. And at that point, it'll be digital treatment. Whether or not we tell it like that, it is increasingly. And I think we need to move away from talking about digital health to just talking about health in the 21st century, because it will all be digital. We cannot rely on paper and cardboard anymore. You all know that, but we need to tell the public as well that it is not in their interests. One of the most powerful tweets I ever sent out was a photograph of the data storage warehouse, which I stumbled upon accidentally when visiting my local hospital at the Norfolk and Norwich, magnificent hospital. I met a magnificent man who was dressed as Father Christmas, carrying the patient records around the hospital in a trolley, and I chatted with him. I asked him what he did. He said he was absolutely crucial to the hospital's performance. So he was carrying these records around between wards, and I asked how many of them there were, and he said there were 60, proud to do the work. And I said, well, where do the records go? And he said, well, to the warehouse. So I changed the itinerary and said, could I go and see it? And I met some wonderful people managing an incredible facility, 10 miles of records just for one hospital. But I have to say, it was a shock for me to look down and know that my mother's medical case notes were somewhere down there, and I saw treasury tags and paper and cardboard. I didn't see anything falling on the floor, but I could see the risk. And the truth is, we need to tell people that that is how the system has been run, and we want to transform it to something much more reliable that will pick up problems and prevent the sort of accidents and mistakes that a paper and cardboard-based system inevitably carries with it. You don't need me to tell you the challenges. We're the fourth biggest organisation in the world, an integrated healthcare system. This is tough, and it'll remain tough. But I really come today to thank you for what you're doing and to tell you we are in government right behind it and not hesitant in any way about taking the leadership that you need from us to support it. We have made huge progress. Last year, as Tim said, we became the first country in the world to publish consultant surgery outcomes across 12 specialties. We've published information regarding GP surgeries, care homes and mental health services on My NHS, which I'm delighted to be the minister responsible for. The Friends and Family tests is taking off. We need to speed it up, but we've now got over 10 million responses. It's not insignificant. Last year, public satisfaction with the service up, despite the difficulties of the last few years, and the number who think the NHS is providing safe care is also up 7%. So something is going right, and there's a lot of success. But we are determined, as Secretary of State made clear yesterday, to go further. And as we're announcing this week, a series of targets, painfully worked out in conjunction with a number of people in this room, but we want to make sure we're clear and able to tell the public what's coming and to excite them and to build expectation and support for it. So by the end of 2018, all doctors and nurses able to access the most up-to-date life-saving information wherever a patient is in England by surgery, ambulance service and A&E, expanding to social care in 2020. Tim's heard me tell this story before. As you walk to my office in the Department of Health, the last picture in a series of magnificently inspiring pictures of the NHS 24/7 there for you wherever you are is a picture of an air ambulance banking over a wave-battered Shetland Isle in a lighthouse. And it makes you proud to be British, that wherever you are, you clutch your chest and you fall and you're picked up by the NHS. There's only one problem. the magnificent paramedic leaning out of the helicopter looking for the patient is carrying a Bic biro and a pad of paper. It didn't work in America, that, because nobody knows what a Bic biro is. After I told that story, I noticed the picture's been taken down. And I really look forward to it going back up with an app and an iPad. And when they come for me, as they surely will soon, I want them to know my vital stats. I want them to know my allergies. I want them to know my preconditions. And I want them to have the dose ready, as do you, as does anyone who really cares about healthcare. There's a whole series of targets that we've put in place. I don't want to list them all, but I think the two I would flag. Within 12 months, all patients able to access their own GP electronic record. We have to take that from something that you have to have a degree in software science to be able to really understand, to something we can all do. And the information at first might be basic, but it's a transformational moment when you start to digitalize that interaction. And by 2018, including all information from all health and care interactions. And of course, all of this is built, crucially, has to be built on the bedrock of confidential medical information security and public trust. I won't repeat what the Secretary of State set out yesterday, but I'm really grateful, Fiona, for your work and for taking on that role of helping us put in place some consents and some cybersecurity protocols and disciplines, drawing on very best practice that will give and underpin that public support. We are absolutely determined in government to make sure that we deliver this prize and that we're able to let the data flow for the benefits of 21st century patients. So much achieved. As I said earlier, I think the crucial challenge for us is to focus in this next few 2 or 3 year period on patient benefits. It's a strange thing. As ministers, we also have constituents, and it's very humbling. The Prime Minister does it on a Saturday morning. You have a surgery, and all of the trappings of office fall away as your own constituents, the very people who put you in office, come in, often with carrier bags, and ask you, what are you going to do about this, that, and the other. When the Prime Minister asks for things to get done, they're a bit more speedy than when I ask for things. But you know what people in my constituency ask? They haven't a clue what life sciences are. They don't really know what I do on a Monday to Thursday. But what they care about is, will you be able, George, to make it easier when my mother falls ill and is referred by the GP to the Norfolk and Norwich and then goes into a community care, that there's some way I can track the diagnosis, the treatment path, where she's being sent to, maybe even check whether there's a choice or whether they're good, and work out who I should be talking to. And could we have it so that all of us in the family can see where she is? And could we have a patient record that actually reflects what is happening to us within a matter of weeks, rather than a record that tracks us a matter of weeks and months after us? It's basic stuff that people really want. People don't live and experience disease in silos that we manage the system by. They live in lives, in communities, in real places. And I think there's a very basic challenge for us there, that we will empower people to be able to track their own care, or very often the care and treatment of their loved ones in the system, so that people have the information, basic information, but important information about treatment. I want to say something about the NIB, because I think, as Tim alluded to at the beginning, actually, as a body, in its creation, it is an important organisation and doing something important, bringing together leadership across this whole sector. And there's a really unique skill and power set here, and I wanted just to take the opportunity to acknowledge that and to thank you for the work that you're doing. It's often very unglamorous and very tough. There's some really difficult technical, legal, organisational, structural challenges which you are grappling with day in and day out. And I think the publication of the NIBS Personalised Health and Care 2020 document actually really sets the framework very powerfully and guides this whole quiet revolution in a very powerful and important way. I'm very struck by the progress that we're making. 6.5 million patients enabled for online appointment booking, 3 million patients registered for online access to GP records. In 2013-14, so this data is out of date, 2.5 million prescriptions online, 1.1 million GP appointments, over 2.5 million patients enabled to use online access to records. But the truth is that despite the capacity of the system to begin to handle this information, I think the next real trick, the next step change, is to really get patients to begin to engage. We have a lot of people who have the capacity, who engage digitally in every other walk of life, who are not yet engaging digitally with the NHS. And that, I think, when that starts to happen, and that must be our goal, to get that happening as quickly as possible, it'll drive up the usage on My NHS, on Friends and Family. It'll get people engaging with this actively and telling us where the benefits are and what the users of this system really need to see us do. And I'm in no small way seized of the importance that this agenda also has for the 5-year forward view. If the system is going to do, as that very powerful document sets out, modernise, embrace technology, become a 21st century healthcare system, and deliver the 22 billion of efficiency savings that Simon and Bruce and the team have set out, it hasn't a prayer of doing it without unlocking this technology and this power of data and digital. So this isn't a nice to have, an optional for 21st century healthcare. This is absolutely essential. I want to say something quickly about apps, efficiencies and the spine, because I think there's been some important progress made. On apps, this is, I think, where the public engagement, the patient user engagement with the system may well really take off first, and I commend the work that the NIB have been doing on it. Patients need to be able to see that on their phone, on their digital devices where they use apps in every other walk of life, in personal finance, in some of the most sensitive transactions we do, that gate swings open in health as well. And I'm really delighted to be able to announce today that we are putting in place a process for endorsing health and care apps properly through the NIB, and that led by NICE and PHE and HSCIC, we're going to help citizens and professionals alike identify a whole range of digital apps that are effective and safe, and that we're going to begin to pilot this process this month. I really think this app revolution may well be the point at which the general public and NHS users begin to realise that a digital NHS is opening up for them. On efficiencies, we all know, you don't need me to remind you, the importance of that 22 billion challenge, and that technology and data and digitalisation and the use of the spine lies absolutely at the heart of it. And it's not what most people in this country wake up thinking about and worrying about. But I think it is important that we tell that story, that this system this vast system has to modernise, and this is not an optional extra. This is absolutely fundamental to it. The spine is one of those things, I sort of dog and duck test. How many people know what the NHS spine is? I suspect it's a very small number. I know you all do. I'd be really shocked if you didn't. I think part of my challenge is to try and generate some public interest and some parliamentary interest in the extraordinary capacity of this system to really lead in this field. And I'll be talking later this afternoon more generally, Simon, about the NHS as an engine of innovation in our society and our economy, an extraordinary powerhouse, and nowhere more so than in digital and data. It's worth reminding ourselves that it provides the basis for the organisation of the management of 28,000 organisations, open or operating 24 hours a day, 1,800 transactions per second, and incorporates a national demographic database of over 70 million patients. This is no small undertaking, and I think we should celebrate and sing out the size and the scale of some of these achievements, and that in its first year of operation, the new spine is going to save the system £21 million, and that's only the beginning. There's an 89% reduction in response time between the old and the new spine, meaning that the NHS is saving 750 hours every single day as a result of this faster, more intuitive technology, releasing time and resources for frontline patient care. It's a great example of what technology can achieve. I wanted to touch, though, before I close, on what for me I think is the most powerful, quiet revolution of this whole agenda, which is about patient empowerment. You and we all know that digital technology profoundly changes the way people interact with healthcare and allows patients and users to take much more control of their healthcare choices and their lifestyle. Whether it's ordering prescriptions, booking GP appointments, there's a convenience revolution there, captured brilliantly in Eric Toppel's book title, The Patient Will See You Now. This is a quiet revolution, and I think we need to excite patients, particularly the next generation of patients, about what this system, this 21st century NHS, will be able to do for them. Yesterday you heard us, through the Secretary of State, set out the goals that we've agreed with NHS leadership, and I wanted to announce today that I will be convening, in order to put the patient voice and the user voice right at the heart of this, as the digital minister in DH, an advisory group bringing patients, national voices, the Patients for Data group, right into the heart of policy making, so we get a relentless focus on the day-to-day experience of users on the front line in the system. The key building block to all of this is public trust and patient trust. And I wanted just to re-emphasise the significance of yesterday's announcements, which we hope will really lock down and cement a public and national consensus that this has to happen. We have to safeguard it with the very best safeguards that we can, that private medical records must remain confidential between patient and their clinician. But the system has to be able to let data flow for individual care, for system performance and safety and quality, and to drive research and NHS leadership in 21st century healthcare. And I hope there is no doubt how committed we are as a ministerial team to achieving that and to bringing the patient voice into the heart of it. I wanted just to touch on the importance of this for research. This is where I came into this. The truth is that data and digital technologies are transforming the way medicines are discovered, transforming the way we diagnose and the way we can detect and ultimately prevent disease. They're transforming the way NICE and the MHRA will detect and assess and monitor and regulate intelligently. And they're transforming the way, data is transforming the way we can reimburse new medicines. And that is right at the heart of the accelerated access review that I've launched and I'm driving through. We want to harness the intelligence of this healthcare system so that we can move from a system that's too heavily dependent on late-stage diagnosis, late-stage treatment in the most expensive places in the system, in hospitals, earlier detection, earlier diagnosis, and the use of that data to make Britain and the NHS the #1 research organisation in the world, which will drive down the costs of new drugs and new devices, because nowhere on earth can offer you a test bed like this organisation. All of that is dependent on us having an open infrastructure and a transparent framework of standards, both in clinical research as well as in data and informatics, to drive research and innovation, and more needs to be done in this space. And enhanced support for that innovation is going to require a realignment of all of our available investment funds, our future technology funds, the investment flows, and new partnerships between the research community, the AHSNs, catapult centres and industry, and I'll say a bit more about that this afternoon. We have an opportunity to combine these technologies, existing, prosaic, known, proven, old technologies, in new combinatorial innovations that will really drive new outcomes and new opportunities across the system. And the stated ambition of the 5-year forward view that the NHS will become, and I quote, one of the best places in the world to test innovations that require staff, technology and funding to align in a health system with universal coverage serving a large and diverse population. That combinatorial technology opportunity is one that this system offers that no other system in the world can offer at this scale, and we need to harness it. Failure, you know and I know, isn't an option. An analogue, paper and cardboard-based NHS isn't going to be safe enough, isn't going to be convenient enough, isn't going to be reliable enough, innovative enough for 21st century patients. So we know the challenge and the opportunity. My promise to you as your newly appointed digital minister in the Department of Health is that I won't shy or duck the challenges of trying to tell the story and persuade the patients, the users, the public, Parliament, press, all the Ps, that this is a revolution whose time has come that can't be held back. But my challenge to you and to the system is we have to make sure that we're focusing on benefits to patients. Of course, there are system benefits, and they're crucial. But unless we deliver patients for benefits, benefits for patients quickly, tangibly, then I think we will end up with this stuck as being something seen for system performance and improvement, important, but not something that patients really need to or feel actively part of and supporting. And that will hold it back unacceptably. It has to be something that patients are behind and can see the benefits of. So I congratulate and thank you genuinely, sincerely for the work that you're doing. I stand ready to support that and you politically, and to make sure you've got the backing you need. Crucially, this agenda needs to be seen to be driven for and on behalf of and in the interest of the people for whom this incredible service exists, the patients and the users. And if we can achieve that, then I think the doors of a digital health revolution will swing open. Thank you.
Well, thank you very much, George. Really, really important reflections. Claire, could I ask you to take the stage? Yeah, do you want to do it that way? Or?
It's not often you get introduced twice, but that's very nice. Thank you all for being here today and for listening to us. My name is Claire Marks. I'm an orthopaedic surgeon. I'm the current president of the Royal College of Surgeons, and I'm here today because I chair the Strategic Clinical Reference Group, which advises the National Information Board on the clinical side of their project. So if I can tell you just a few words about the SCRG, essentially we know that anything that is pushed out as a benefit for patients will probably be much better received if the professionals who treat those patients actually are encouraged and enthused by whatever it is they're dealing with. There's nothing like having somebody saying, I've got something great that's going to help our consultation to ensure that the patient thinks it's going to do them some good. And that's why it's so important that the clinical users, who at the moment on our side are going to be the healthcare professionals, should feel confidence in whatever is produced by way of digital technology. And so what happens at the moment is a two-way process where we will make suggestions to the NIB about our concerns and our ideas, and we will take outputs from NIB and look at them and try and put them into some sort of clinical perspective. So at the moment, we have been having this two-way conversation, but one of the things that has happened is that we've been able to look at things like oxygen, and today I'm very pleased to be able to offer a presentation of the Oxygen app, which is a smart tablet app which is developed for an Apple iOS pad. I'm having to read this because it's not an intuitive part of my normal thing. What's interesting about it is it can be used by anybody who has been registered for the old-fashioned NHS smart card. I've got one in my handbag, and it has a specific registration number. So anybody who is registered on the spine will be able to use this app, but without the use of the actual smart card. In other words, it's something that you will be able to carry around with you and have a very smart clinical interface there at the point of your patient consultation. So far that we've managed to have the app looked at it to view the summary care record, to look at patient demographics, child protection issues, and some other parts of the information system. And so what we're hoping to do today is to show you where we are with this app. What's really good is that it's able to be developed very quickly, it's intuitive, and it draws in clinicians at the coalface to be part of any developments that need to take place, either on part of the app or in the system which it's trying to serve. So it can have dual benefits at that level. So I think Peter is probably going to be doing most of the speaking. Peter is a GP who has worked with HSCOC. And Michael, I think, is going to be driving some of the technology on the app. So thank you very much both for coming to present. And there will be some time for some questions afterwards. Thank you.
Thank you very much, Claire. Good morning, everybody. I think Claire's done such a wonderful summary. I wonder why I'm actually needed here at all. That's obviously surgeons are very bright. They can catch on to things intuitively and quickly and get down to those nitty-gritty points which we make. But I'm not going to repeat what's in the information flyer on your desks. My name is Peter Short. I'm unashamedly a GP. I happen to work in the lovely town of Buxton, quite near to here. So I'm a GP first and foremost, but I'm also spending a lot of my time giving some clinical advice at HSCIC. And my colleague Mike, who will do the driving, is also a clinician, a physiotherapist, but also gives a lot of time to HSCIC to drive forward some of this innovation. I think it's important to repeat this scene setting that in health and social care, one of the biggest challenges we have at the moment is organisations which are often seen as data-rich but information-poor. And that's particularly the case in some areas of the coalface. I'm lucky I'm a GP. I've worked with clinical systems on my desktop with increasing amounts of information for the last 15 to 20 years. But when I'm taken away from that information resource, I feel naked, I feel nervous, and I don't feel I'm giving the care to the patients and the citizens that they deserve and they need. And that's potential when I have access to that information. And one of the key elements that we've talked about is this this element, the smart card in the NHS, which is effectively my key into this information. But actually in our era of openness and reassuring the public and reassuring our clinical colleagues about the security of information, this is a really important device. If I turn up at work and I haven't got this, I have to go back home. And it's that important. It's just as important as my bank card for every day. But it's not only the key, it's also the key to the audit trail, the marker, the footprints of where I've been. So in terms of the future transparency agenda, this item of technology means that everybody knows where I've been, what I've looked at, what I've done. It holds me to account for my professionalism. Now, what we're going to show you briefly, and it's very important that we wanted to show you a live demonstration because the picture paints more than 1,000 words. This is, for security purposes, not the live national spine, and it's not a real patient. So this is fictitious data on the test spine. Very important to remind yourselves of that. But it is happening live now, and as with every live demonstration, it has its own risks. So not working with children and animals is also accompanied by not working with technology. This particular app was developed by HSCIC, by the Systems and Service Delivery team, as a proof of concept. And it really came from an increasing demand from the service, from those users who are mobile, who don't sit there with a desktop computer to say, I really need this information wherever and whenever I'm with a patient, irrespective of the location. And this is maybe one tiny piece in that picture and that puzzle to open up the access to, initially it will be key data held from national systems, available when and where needed by healthcare professionals. So it's integrated with the National Spine Services and the data sets. The important piece at the start is to associate this identity of the smart card with a device. So effectively, the registration process, the secure registration process, links my identity and my smart card to the device. And that's really important so that no longer do I have to have an expensive reader or other technology. That becomes my smart card. I still have the security I have to go through on the pins, and I still then have other levels which we'll show you on the device now. But the important thing is it gives us the confidence that this is no less secure than my desktop service I'm currently operating. Mike's going to start demonstrating, and hopefully I will remember which of these bits to use. Now, at the moment, this is out in our first proof of concept with 3 enthusiastic areas with up to 50 users. So we're at the very earliest stage, showing you what we're anticipating we'll view. So Mike's going to log in with his pin to the Project Oxygen app. And he also has the benefit of using one of the other whizzy bits of technology, the fingerprint identification, to confirm his identity on his device. So there we are in the app, first of all. And what he's going to do is to search for an individual. We're doing some shortcuts. We're using NHS numbers because at the moment it only has a simple search facility, and it will only pull up an absolutely perfect match on the test spine. So this is Melinda Gibb, and it's asking, is that the correct patient? Yes, it is. And we're now connected to the spine data. Now, on the bottom here, you'll see in the centre at the top, we can see it's Melinda Gibbs. We can see her other previous names. At the bottom, there's a series of tabs which shows her home address, her previous home addresses, her postal addresses, temporary addresses, any email contact, and a variety of telephone contacts, all information that's currently stored in the patient demographic service. Next element, we're going to have a look at other relationships tab. On the left, you'll see there are 6 tabs down the left, the top one identifying the patient. The second is an identifier for relationships. Now, there are very few people on the spine who have a linked relationship, but on our test spine, we've actually put some linked relationships because it makes it easier to locate them and show you bits of the system. Underneath this, we are still bound by our professional duty to observe the legitimate relationships, and because all our actions are tracked through, if we were to attempt to access records for which we didn't have a relationship, there'd be a trail through to audit what we've done. But we're going to have a look here at, is it the father? Yeah, we'll look at the providers first. So first of all, we'll look at the providers. Who's been looking after Mrs. Melinda Gibb? And here we can see that the usual practice at the top, This has got some test data, so there's a regular practice. There's also a temporary practice below it at which she's been registered. Also there we have the details of the pharmacy for which she's registered for the electronic prescription service. And the next tab below it is, again, using what's now pretty common for those of us who use smartphones and apps. Very simple to link into maps functions to locate where are the various services and the various agencies that this patient has become in contact with. There's a legend at the bottom that shows where they've actually been in contact with, where their relations are, and where the various provider units that look after them. So going back now to have a look at the father's records. And this is to show another part of it in the system, the summary care record that we'll be identifying. So here, this is Mr. Sean Eldridge. And on the left, you'll see the tab next to the bottom says GP summary. In the previous record, that was greyed out. It wasn't available. But this is a gentleman for whom there is a summary care record. And I probably don't need to remind some of you, but in the UK, we now have 96%, well, in England, we have 96% of the population who have a summary care record. So for almost everybody, this basic core safety information of medication, allergies and adverse reactions is available on a national footprint. Now, of course, to go into that, we have some well-established governance rules, and this app will exactly follow the currently established governance rules to access the summary care record. So it gives us an option of, does the patient give us their permission? Yes. Do they decline their permission? Or are we going to actually claim access to this information in an emergency scenario? And we press that button, but then we're asked to justify in the free text form why that has actually happened. This will also trigger an automatic notification to the privacy officer, so it will almost certainly undergo some investigation to see why somebody has overridden access to the summary care record without patient consent. So we're going to continue and confirm our access request. And this is what's available currently in the summary care record. There's a lot of test data that we've been putting in, playing with it. But the core elements are the acute medication, the repeat medication, discontinued repeats. This patient also has a summary care record with additional information. And in England at the current time, we now have our two major suppliers who both have rolled out the ability for clinicians in primary care to add additional information into the record. This is done with express consent, but will give us the opportunity from now to be adding a much richer data set to be available in the core summary care record. So quite an exciting prospect. Exactly how we go about that and who we target that with is the subject of some debate. But from our point of view, what this app does, it makes that information available as and when is needed on a mobile basis. We're also able, within that summary care record, to search for items. There is a search facility, and Mike's just searched for asthma there, and it shows whereabouts within the summary care record entries the various elements can be found. So if you're not sure and you had a very extensive summary care record with additional information, it would enable clinicians to search for various entries. Okay, we're going to have a look back and go into the child and probably find have a look at the child protection information system. So again, we're back through Mother, we're going to the relationships tab and find her record and then relationships. And there is the child, Jason. That is the correct patient. Don't you just love the spinning wheel? What this will bring up shortly, and I've got total confidence in it, is a list of the individuals who's searched for the child protection information on this particular child. And again, this is a small tool, it's a key to raise that awareness that this is potentially a child who is maybe more vulnerable. There are 3 potential statuses that can be logged on here, but this is a really important way to make that information available to key individuals for the protection of the safety of children. So that's been a bit of a brief summary, a very quick view of what's available at the moment. One of the things to point out is that although this innovation, I would say that it's patient-centric and it's clinically led, it's clinically led in close partnership with the technologists, and this is really important in accelerating our future transition, is that clinicians and patients and technologists need to work closely hand in hand, because individually they have different ideas, but together they can work to quick solutions and bring them to the market and develop them. So we expect this to be continually iteratively developed at a very, very rapid pace. I cannot tell you what will be added in. I can't tell you what else this will be the key to. But we think this is a significant innovation that's got technologists, clinicians, patients, and the provider organisations quite excited. So I hope maybe in a year's time when we come back, there'll be a fantastic national story. Mike and I are happy to very briefly take questions, if that's okay from Tim. No, okay. I'll be around for a while afterwards if anybody has any specific questions. If not, on the sheet you have in front of you, there is a contact address if anybody wants to get back to HSCIC and ask more, or please call me later. Thank you for the time.
Thank you, Peter. Thank you, Mike. And thank you, Claire. Great. Right. Fiona, perhaps I could invite you just to update on National Data Guardian.
Thanks, Tim. And good morning, everyone. You've got a short report from us on work we've done since the last NIB report. I thought I'd just refer to the headlines that Secretary of State gave in his speech yesterday, and I hope colleagues from the CQC won't mind if I refer to the work that they're being asked to do as well as the work that I'm being asked to do. So essentially, to review standards of data security for patients' confidential data across the NHS. And I'm going to contribute to that review by developing clear guidelines for the protection of personal data, to which every NHS and care organisation will be held to account, and that includes cybersecurity. So advice also on the wording of a new model of consents and opt-outs, which are to be used, particularly, as you've heard in speeches already this morning, in relation to patients and the public. And I don't think that's the least of our challenges, to have a simple statement about consent and opt-out. So that's going to be an important part of the work, and it's clearly vital for the NHS and for the public that it serves. This has to be completed by January, and the new guidelines are going to be assured, I think, from April, but I'll leave CQC colleagues to talk about that on another occasion, through their inspection regime and through NHS England's commissioning processes. So this is a series of pieces of work which obviously are now going to be discussed in some detail to see how that's taken forward. And you'll also be aware that the consultation on the role of the National Data Guardian is being released because Secretary of State wishes that that is put on a statutory footing, so it's absolutely clear that there's authority in relation to the role, rather like that of the Chief Inspector of Hospitals in the CQC. So that's the small agenda I've been given since I got back from France on Monday evening, and if I'm looking a little frayed, you may understand why, but I'm happy to answer any questions, but that's the latest news. Thank you.
Thank you, Fiona. If anyone does have any questions, or David, do you want to say anything on behalf of CQC? I think just in terms of if anyone has any questions.
Thanks, Tim, Fiona, and other colleagues. Just to emphasise, the speed at which this has been put together, I think means that some of these joins and conversations, which I think should have taken place, that haven't quite been able to take place, we'll put that right over these next few days. I think Fiona states this well. We're asked to do a review. The significance of this is we're not building this into inspections between now and next April. We'll use some of the methodologies that we've got to do reviews. You might hear us talk about thematic reviews at other times, and it will be of that nature. I think that one of the first things we'll do is pull together a workshop of people who've got expertise in this to actually have a conversation with them, and then we'll begin to undertake that review over the timescale working with Fiona. I know colleagues, Andy and Kingsley are here from the Health and Social Care Information Centre. There's a whole bunch of conversations that I think need to take place. Our new inspection, our new approach to inspection will begin when we've completed the current round of inspections. So we're not looking to retrofit what we currently do, rather as part of our new strategy, build it into our new strategy. And we'll consult with that over the summer. So we'll work with Fiona. We haven't had a chance to correspond over this, but there's been lots of digital traffic between us, just to emphasise the D in this, and we'll straighten some of those things out. So hugely important issue about the security. I think it's a foundation stone on which a whole, and I think George Freeman was referring to this, a hugely important set of transactions needs to take place between agencies, not just within the NHS itself, to ensure that people get access to the right care. This is about care for people, not about systems, and the way that CQC will come at it is about how does this ensure people get access to the right quality and safety of care, and how does information and the exchange of information, and it's being stored confidentially, support better care for people.
Great, thank you very much. Any quick questions? Great, thank you very much indeed. Right, so now we move on to kind of the, in a way, the conversation about how we are delivering on the framework from November, and I'm going to hand over now to Rebecca Challoner. I think I've laid the context in my earlier remarks, just to guide us through this piece of the meeting. But can I just repeat my thanks to everyone who's worked so hard on this? I mean, this might look like condensed into 5 or 6 slides per item, quite a light touch kind of piece of work, but it has been a phenomenal team effort by everybody, really, all the organisations around this table. So just thank you again for that.
Okay, thanks, Tim, and welcome everyone. I'm Rebecca Challoner, and I'm heading up the NIB Secretariat and Implementation teams. I'd like to talk to you briefly around 3 things this morning before I hand over to others. The first is just to recap on where we've got to in implementing Personalised Health and Care 2020. I want to just touch as well on what we agreed at the June leadership meeting, and then update you on what's happened since June. So if you remember, Personalised Health and Care 2020, the National Information Board framework, was published in November 2014. And one of the things that really characterised it was the amount of collaboration that had gone into producing it. NIB members, all of you represented in the room, had worked together and with others leading up to the publication of the document. And it's been fantastic to see that collaboration continue since then, as we've looked at how we can deliver the commitments in the framework. I think it's also important that we remember that we're part of a wider transformation, and that the National Information Board is one of the contributing boards for the 5-year forward view, and that as well as collaborating in this room, we are beginning increasingly to collaborate with the other boards that make up the 5-year forward view delivery structure. When we looked at how we could implement our blueprint, the recommendations in the framework, you'll remember that members came together in work streams to deliver roadmaps that were aligned to the chapters of the framework. And in June, we received draft roadmaps for each of those work streams, and they've been available on the website, and there's been quite a lot of work done around them since. Also at the June meeting, we looked at the new 6 domains for delivering the programmes that are coming out of the roadmaps, and we had some discussion around them. The domains are up there, the main ones you can see in the green boxes, and they're supported by cross-cutting work streams. Alongside looking at the new domains for delivery, in June as well, we also heard about the important work that's being done in partnership between the Department of Health, NHS England and the Health and Social Care Information Centre to assess and prioritise the proposals that are coming out of the roadmaps alongside the current informatics portfolio, to develop a portfolio of programmes for each of the domains that will help us deliver these transformational domains for delivery. And we're going to hear a little bit more later this morning around how that work to assess the portfolio of programmes is progressing. So So looking at what's happened since June, there's been quite a lot happening in the 3 months since we last met as a leadership group. The roadmaps have been the subject of a wider conversation. They've been tested with stakeholders through workshops, regional events, national events, focus groups and meetings. I think in total more than 90 separate organisations have been involved in wider conversations. We've had we've received comments as well through the website and through social media. The work streams have all had access to that feedback on the wider conversation, and they're now refining the roadmaps to pick up what people have been telling us, with the aim of publishing final roadmaps at the end of September. Talked as well around the work that has been going on to assess the portfolio, and we'll hear about that shortly. But in addition to developing plans, National Information Board members have also been busy delivering some of those initiatives that are in the Personalised Health and Care 2020 document. We've outlined them here. I'm not going to go into them in any detail because we're going to receive updates from those members who have delivered things since we met in June. I'd like to hand over now to the first group who are going to update us on delivery, and hand over to Simon Stevens, Chief Executive from NHS England, who will introduce the delivery update on providing patients and public with digital access to health and care information and transactions. And Simon will be followed by Beverly Bryant, Director of Digital Technology at NHS England, and Dermot Crean, Deputy Director of Digital Public Health England, who will update us on the details.
Thank you. Yes, I'll run through the details in considerable length right now. No, actually, all I will say before handing over to Beverly is that I do think that since we had our June Leadership Summit, there has been quite considerable momentum on this part of the agenda, as on many others. I think those of you who've had a chance to wander around Expo this morning or yesterday will have seen that we are pushing at an open door. There is real pull demand for the kind of solutions that we're talking about here. This is not just kind of push as part of some national infrastructure. The key operational challenge for us now is the prioritisation and the sequencing of what these will look like in different parts of the country. Talking to folks this morning, for example, in Dudley versus Wakefield, different starting points, different problem sets, different degrees of strategic freedom, if I can put it that way, in terms of how they go about it. And so the ask that we're making of them is a twin ask. Firstly, that they complete digital roadmaps by April. The ask is of CCGs, but the reality is that's got to be whole health economies, whole health systems, strong provider engagement. And as they do that, we want to try and mark their card through the production of this digital maturity index, which work is still going on, but I think come October, November, we want to have got that nailed so people can kind of use that as a basis for the conversations in charting their own digital roadmap. So those are the kind of two key things, frankly, we need to land out of the local NHS over the course of the next 180 days or so. And at this point, Beverly may want to come in with more.
We've done some slides, thank you for that, to give an update on where we are on 1.1. The main thing, there's a couple of things that have happened since summer. The first thing has been much more engagement. We spent a lot of time in the run-up to the publication of the roadmaps in June, just testing the ideas with members of the public, with the clinical community, and we've done a lot more of that. We've created a video called Eggbot, and that's been in response to the fact that our public are telling us it's all a bit too techie, all this stuff. We don't really understand what you're on about. Now, that's been received quite badly by the clinical community because they think it's anti-GP, and the cold fact of the matter is it's a hard balance to strike. We have to bring our clinical community with us if we're going to revolutionise care for our patients. But we've also got to speak to our patients and public in a way that they understand. And it's really hard to get that right. We always say that this is about changing the relationship between the clinicians and the patient. And certainly in primary care, as Peter alluded to earlier, we're already seeing that come forth. So that's another thing that's been going on. The NHS.UK vision that we have, we've also created an alpha. So there's a team now brought together from NHS England, Department of Health, GDS and HSCIC to develop an alpha, some journeys, user journeys, to test out with our public how people can access their own records, access the NHS new e-referral service that went live in June, and also put themselves on self-care diabetes journeys to manage their own diabetes. So we've got those tested through. One of the big points I really need to make about 1.1, about Domain 1 and putting things in the hands of the public, is it's not enough just to build the digital journey. We have to make sure that we have a fulfilment model at the back end. So I'm going to give you a few examples to bring this alive. We have a national way in which the European health insurance card is fulfilled. If you want a European health insurance card, the old E111, you go online and one organisation creates those cards, the BSA, and they send it to you. So if we put a digital front end on that, 100% of the time, it'll work. But if we build an NHS e-referrals app that allow patients to go online and change their appointment and cancel their appointment, and it's all fantastic, what's the point in that if only 52% of our referrals are actually handled electronically and the other 48 are handled in paper? So it's all right having the front end, but we've got to match it with making sure that we have the full digital back end. Otherwise, our public will be disappointed. 7,950 GP practices, if we put an app up that says, log in here on NHS.uk and access your records, and they say, we're really sorry, but your GP is not offering this service at the moment, it's just not going to cut it. So we've got to make sure that we move the back end in parallel to the front end, but make sure that at the same time, that's why we have to bring our clinical workforce with us. So again, we've loads to do. Fabulous that we've still got momentum. And with that, I will hand over to Dermot.
All of your slides that you didn't use. So my name's Dermot Quinn. I'm the Digital Director for Public Health England. And I just wanted to add to a point that was made earlier on. It's been really fun working and really interesting working with my colleagues from NICE, HSCIC and NHS England on this project. It's been a really interesting thing. What I'm just going to take you through is the assessment and endorsement model. The key thing to note is these words, assessment, endorsement, it's a very difficult topic because each word that you might ascribe to this has so much connotations for different parts of the health system. Endorsement means one thing for NHS, assessment is another thing for NICE. So we are, at this point in time, moving into a pilot phase. George mentioned earlier on that we are moving into a stage of looking at this process and really checking to make sure it works. And the language that we're using is one of the things that we're validating. So just to be clear that language is something that's different. But just take a step back as to why we're doing this. This is a study that was done on the smoking cessation apps in the app stores, be it Google Play or on iTunes library. It was a study that proved that, or showed that, people can't find a good app from a bad app. If you looked at the researchers looked at the 247 apps and then whittled it down to 50 or so, and what they discovered was the star ratings of an app or the cost of an app didn't make any difference from the correlation to the effectiveness of an app. And they looked at each of the apps and determined how effective they were by comparing them against known processes to quit smoking. So there were some apps that did anything like a process, and they had a high price or they had a high star rating, and you can see the point. So what this tells us, for what we're trying to develop with this endorsement process, is that the health application market isn't working, and an endorsement, some kind of assessment process is necessary to make it work. When we've spoken to various developers and stuff like that who are making health apps, they are crying out for some way to put their head above the parapet of the 300,000 health apps that are out there. And we've had many, many really positive conversations with developers who are keen. So our pilot process that was mentioned is to start with 2, just to test out our model. It's a very early pilot. I want to reiterate the point. This is an alpha product that we're piloting, and it's a very early phase thing. But the key points to note from this study is the whiz in the crowd doesn't work. People aren't able to decipher good apps from bad apps, and the health apps market isn't working. So the endorsement process needs to be brought to place, but it facilitates developers to generate revenue so they can sustain themselves. That's the key to what we're trying to achieve. Now, the other thing to mention is this process is not going to be simple, and we are, in our roadmap, we even acknowledge the fact that there is a likelihood that this may not work. We want to be really candid about the fact this is very, very difficult, hence the need for a pilot. the three kind of key problems that we're facing are encouraging innovation. So if you set the process as being too complicated, then it will kill out anybody trying to come into the app space with a kind of innovative idea. So you can't set the bar so high that people just walk away from it. But you can't set it too low that those people who have made the effort to make really good health apps don't think it's worth going through the process to get the stamp and therefore then show themselves to be good. So it's this kind of find the right level. We know from speaking to various people in our stakeholder groups that GPs or citizens and so on need to have a lot of trust in this process. If we don't tell them what's good or bad about this what's good, what these apps are worthwhile, and we don't make sure they really believe that this is a good accreditation, then they won't have any faith in it and it won't work. So there's a big part of this about making sure that it's properly trusted. And obviously, there are, as I mentioned, 300,000 health apps in the market. If you got hit by all 300,000 apps tomorrow trying to be accredited, this thing would fall over in an instant. So there's an aspect of trying to devise a process that can scale but also throttle, so you can manage your flow. And so that's the considerations. There is this push from either side that this arrow at the bottom illustrates, which is, on the one side, allowing it to be very light and fast so that innovation can flow through really quickly. On the other side, to make sure that the things that get accredited are the applications that will solve some of the big issues in the health system. And we're trying to find that balance as well. And we think that we've cracked it, or at least the pilot idea that we're taking forward we think is a good one. Just to describe the process, so it's a 4-stage process. And the bit that we're piloting, this is very important, the bit that we're piloting is the first phase. The first phase is a self-assessment. So a developer, somebody who's created a health app, comes to a website which you've built to help kind of consider the policy or the concept, and they go through a series of questions. The questions change as they go through them. We are starting that process with 2 apps in the next week or 2, so this is the pilot that was mentioned, to test out this process, make sure the questions are okay. And as you can see, there's a number of areas in which those questions are going to be asked. I won't go into too much detail, but the point being that when they get through that self-assessment, there's a level of onerousness to it, but it will basically allow us to publish what they're saying about their app, and so that others can come along and say, is this app stand up to what it's claiming? Then you move into the second phase, which is crowdsourcing. So this isn't necessarily open to everybody, but building communities around a theme, so let's say it's diabetes, building kind of clinicians or maybe from the charities who can come together on a kind of a community-based place and all input their opinion and help the app, the perception of the app, or the verify the data that the app developer is publishing, make sure it's correct. So this is, and the process that we go through the first pilot of this, we'll be developing the crowd aspect of this as we go. This is not something we've built first. We're going to be figuring it out as we move. The third phase is to demonstrate that their app is effective. So there's an academic involvement that we are requesting from them. And then the last one, when we see apps are a larger value, then the system itself might choose to do an independent evaluation. This is just totally not showing up on there at all. I do apologise. Basically, just to kind of demonstrate how we're trying to do this, Public Health England has decided to make a smoking cessation app itself. And the reason why we're doing this, in part, is because it's one of Public Health England's major priorities, but also the process we're building it is going to allow us to prove this model is working for ourselves. So not only are we inflicting it upon others, we're also inflicting it upon ourselves to demonstrate its value. The logic being that we're building an app that spits out data that's going to this picture was supposed to describe the stages of the app, and all the data coming out of the app going to academia and to researchers, so we can prove that the app is helping people to quit smoking, not only during the process, but also over a period of time afterwards, and go through all of the pain of this process ourselves to make sure the data's secure, it's in the right places, that the whole thing is done as per the process. So that's an update from where we're at right now. Thank you.
Thanks, Dermot. I'm now going to hand over to Rob Tinlin, Chief Executive of Southend-on-Sea Borough Council and now Local Government Association representative on the National Information Board. And Rob's going to introduce the delivery update on the digital roadmaps in readiness for paper free. And Rob will be followed by Paul Rice from NHS England, who will update us on the detail.
Thanks. I'm going to follow Simon's lead by doing the intro from here. And it's a bit like one of these coastal resort comedy postcards. It's a Scotsman, an Irishman, and an English health service sector here. And I co-hosted this with Stephen Dunn, who can't be here today, from West Suffolk Trust. The focus of the work stream for 2.1, as we've heard and you will remember, is to give care professionals access to the data they need for better direct care. Now, that's about higher quality, more efficient, more integrated, more responsive. And it's not just about health professionals, it's about the whole health and care sector, up to 2020, as we heard earlier on. The board will, of course, remember from June the 2.1 roadmap and delivery programme was presented there. What we're going to look to is to give you a bit more detail in the stakeholder engagement activities and the detailed progress on specific work packages. And I'm going to look to my expert colleague Paul there, the Irishman in the team, from the Head of Technology Strategy in the NHS, who, with Mark Gollage from the LGA and some really, really good people, I have to say, NHS have got some really good folk under Paul, and acknowledgement to Mark as well, have produced some really good work. And of course, Tim, you did some launches this morning.
Thanks, Rob. Clicker works. A little bit of a reprise, really, about the current state, future state that we're aspiring to here. Again, these are sentiments and ambitions and indeed imperatives that people have heard about and have been reiterated across the last 2 days, and are at the cornerstone of the National Information Board's work. So we know our current state is over-reliant on paper. There's a mixed adoption of the key standards that would underpin an interoperable system. There's a huge variation in digital capability, and there's inconsistent information sharing across care settings. And what we're actually aspiring to do and need to achieve is the future state where that information that's available to people is timely and reliable, that there are open systems and a widespread adoption of those key standards so that the information can flow effectively and without additional effort on the part of the recipients of that information, a sentiment we borrow from our colleagues in the United States, that local areas are making this progress and that they're adopting best practice as they press forward, and that the system as a whole is exploiting those opportunities where automation of the care service will actually deliver efficiency benefits, quality benefits as well. We had 7 areas that we identified in June that we thought this work needed to focus on. I don't want to reiterate those, but they are of a piece. But we have been involved with colleagues in a whole series of roadshows and engagement events. The 2.1 board. So we deliberately set up the 2.1 board with as many interests around that table as practically possible. It doesn't always make it the most manageable meeting when you look to Stephen or Dunn to chair it, but it's an incredibly rich narrative that we've had as we've built this work, and I wouldn't want to have done it in any different way. But I'd just say, even in the summer period, that engagement activity and that contact with local organisations and local systems that are already making heady progress on this has continued apace. What I just wanted to focus on today really is the 4 areas that we've honed in on and are kicking on with, really. And Simon picked it up in his sort of the chief executive of NHS England used the 180-day phrase, puts a chill in you, but it's absolutely where we are at the moment in the context of this agenda. So we published today guidance to the local health and care system about them identifying the footprints by the end of October, the basis upon which they will then create their local digital roadmaps by the end of April. Very clear how that process has to be inclusive, very clear how CCGs have leadership of that agenda, but they must involve their providers, local authorities and citizens in that activity. And included a couple of illustrative templates for people for the sort of thing we're asking back for them. And again, significantly, have absolutely placed that responsibility in the mainstream commissioning and delivery agenda that NHS England and colleagues coordinate. So commissioning operations colleagues are instrumental in that work, and we have the support of Dr. Paul Watson, the Regional Director at Midlands and East, in pushing forward with that work, as well as Beverly Bryant and other colleagues. So that's been fundamentally important.
The creation of the Digital Maturity Index, again, Simon alluded to earlier on. We need a comprehensive baseline as to where the NHS is currently in the provider environment in relation to exploiting these technologies. And we also need to look to see and assure ourselves that where the opportunities exist, people are taking it to move that information effectively between care settings, because it's no longer sufficient to be just digitally mature and capable in the bounds of your organisation. Patients move, care moves, care requires pathways to be followed and information to flow across. So we're actively in a beta with that tool currently. We've half a dozen NHS organisations and local care economies lined up for later on in the month to get to grips with what we've done and to sort of test it to destruction with the intention of publishing the first request to the system as a whole at the start of November. Interoperability, perhaps a slightly more technical aspect of this, but was again instrumental from our point of view in terms of delivering this 2.1 work package. There has, again, a publication today and a co-created piece of work. We know, Tim mentioned in his earlier presentation about the work that's been going on with Andy Kinnear colleagues down in the southwest. They are one of a number of health and care systems that are already cutting a dash on this agenda about interoperability and information sharing. And there's been a really, really important engagement led by Indy Singh and at NHS England and colleagues in HSAIC with those examples of the vanguards, the Better Care Fund, the integration pioneers and others who are already doing some of this stuff, and we've been sucking up all of that best practice in those examples. And that interoperability handbook is published out to the service, not to say you have to do it this way, but here's the lessons that we have drawn from your peers. Have a look at these. Have a look at these technical patterns. Have a look at the way in which people are making the justification locally for information sharing and interoperability, and see why wouldn't that apply to your circumstances and context. And then the last piece of work, which other colleagues will pick up in detail later on, is this contribution that a number of the work streams, or all of the work streams, have made to work stream 7's undertaking in relation to understanding the current portfolio and building the case for the comprehensive spending review and sustained investment in this agenda. So as with everybody else, a busy summer period. Clearly a very busy 180 days that we're just about to embark on in relationship to these key assets, and a whole series of ongoing conversations and engagements with the service to drive this in a way which makes it mainstream business, as Tim has alluded to, rather than a technology sideshow. Thank you.
Thanks, Paul. I'd now like to invite David Bean, Chief Executive of the Care Quality Commission, and Paul Bate, Director of Strategy and Intelligence at the Care Quality Commission, to introduce the delivery update on progress towards secondary uses of data. And Geraint Lewis, who's the Chief Data Officer from NHS England, will then update us on the detail.
Thanks. What secondary uses of data? I think what this is about is beyond digital technology and technology being used to support individual care, is about how data is used to support the improvement of services generally, so they act in the interest of people using services. And Peter earlier talked about information-rich, data-rich and information-poor. Well, I think what this piece of work is demonstrating is that is true in some places some of the time, but there are other places where we're information poor and data poor as well. So what this is about is presenting and developing a roadmap where we can look at how we use the current data and information we've got to improve the quality and safety of care more generally, but also for those areas where there is insufficient information and data, what more can be done. Classic examples of this are community healthcare services, some aspects of mental health services, and when the conversation is about the integration between health and social care, the relationship with social care, where in previous incarnations I've referred to that as a data desert. So there is an issue, if we really are going to join these up, about how we can set out that roadmap and establish a robust approach to development of information and data which helps us to drive and encourage continuous improvement, identify variation and explain to the public more clearly the changes that we are seeking to make, and pick up on Beverly's point, do that in a language that they understand. So that's what Workstream 2.2 is. If you say, come to a talk on Workstream 2.2, it doesn't seem interesting or sexy, but come and actually have a conversation about how we can use data to contribute to the improvements in the quality and safety of care, I think sparks a different level of interest. So Geraint is now going to take us through the detail of that. I'm very grateful to colleagues in the Health and Social Care Information Centre, Monitor, as well as NHS England and my own colleagues in CQC, Emma Rourke, who've led this work as part of our responsibilities under the Framework for Action. So, again, just to continue that theme, this is a team effort. None of us can do this by ourselves. We can only do it working together. Geraint.
Thanks, David. So now it's the turn of the Welshman. As a public health physician, it'll come as no surprise that I'm really passionate about the potential of data to improve the health of the population. So it's a real privilege to be involved in this work stream, and I want to echo David's comments there. That we've really come together and gelled as a team, working with colleagues from CQC, but also from Monitor and the Information Centre. Workstream 2.2 is all about data for secondary uses. In other words, using data not at the point of care, but for all the other things that data can be used for doing. Specifically, our challenge is to develop a roadmap for comprehensive data, in other words, covering all settings of health and social care, which can then be used to improve the quality, the efficiency and the equity of health services and health and care services. And we've set about our task using the three lenses of the five-year forward view. In other words, sustainability, quality and prevention. Our vision for the long term for secondary uses data was outlined in the... This is on automatic forwarding, isn't it? It's trying to get me to move forward. Our long-term vision for secondary uses data was outlined in the framework that was published back in November. And essentially, we want to move away from the data having to be collected in parallel. So as well as the basements that you heard the Minister talk about earlier that are full of paper and cardboard records, there's also a department typically that will be turning information from those records into coded information that populate our secondary uses databases. We want to move away from that and instead to rely on data flowing from one point of care to another, and then to take a side feed of the data from those messages that were generated for clinical purposes that will then constitute our database, our collated data sets. The benefits that can be derived from data are essentially limitless, countless different purposes, but we've grouped them here in terms of data for research, data for predicting and preventing. Sorry, I'm feeling a bit faint. Yeah. Emma, would you like to do it? Yeah. Right.
So, the benefits of 2.2 that we're looking to realise go across all secondary uses. So it's planning, regulation, oversight, management of health and social care. So we're looking to improve the awareness of data that exists and how you can properly harness the information in order to derive improvements for patients. We're looking for the information to also support choice. So it is also about how the organisations do run themselves and how they conduct their affairs with the patient at the centre of what they do, but also how that can interface directly in the public interface, how members of the public, citizens, patients, people who use services, use that data. So we've set out our vision. We want to engage everybody who has a stake in secondary uses data. We've run a series of events involving people at both a national level, but also invited people from local groups, commissioners, regulators, such as myself. We had a workshop dedicated to providers. We had a workshop dedicated to academics and think tanks. So we tried to get broad coverage of all of the interested parties to make sure that when we go out with our roadmap, it's representative of the system as a whole. So we've done 4 focus groups, engaging with the groups that I've discussed, a number of national workshops, and we've also had dedicated one-to-ones with some subject matter experts. Some of you are in this room, and we thank you for the time and the energy that you put into those events. We tested our initial document that set out some preliminary priorities. David, in his introduction, highlighted certain areas: adult social care, unplanned care, community health, mental health, which our initial analysis through PERDA had identified as being significant gaps, both for improving data that exists, but also generating better data to fill those voids. They were received very well, and the events that we held were both an opportunity to hear from people who are desperate and have really constructive ideas and hypotheses which they wish to test the data, but also gave us really good validation of how far we'd got, particularly through the PERDA period where we've been limited for who we could talk to. So in total, we had the views of over 200 people and the organisations that they represent through that process. So our findings, as Geraint said at the beginning of the presentation, we looked at our priorities through the lens of the key themes in the 5-year forward view: sustainability, prevention and health. And we, in our very sophisticated manner, applied stars, and we used those to just give quite a transparent general view that we tested with our programme board. So our roadmap that we are looking to publish later this month will list those outputs. It will feed into a longer term programme to turn this vision of addressing gaps and improving data that we have into reality. We're looking at harnessing existing programmes, so we're not looking to create additional bureaucracy or governance where we've already got programmes in place. So work that's going on around genomics and PLIX, we want to very much exploit the work that's already happening in areas around adult social care, mental health, data development. It's about us endorsing that work, making sure that we, as the National Information Board, stand shoulder to shoulder with those people that are currently investing in that work that we believe serves the purpose of the ambition of 2.2. So, I think this is my final slide to you, is just sort of summarising the outcomes and the proposals that we will have. So, as I've already said, we very much want to place an emphasis on enhancing existing information. There's been so
because it's all very well talking about apps, but and the apps revolution, but we've got a few things to do to get our house in order to enable this around infrastructure. So George mentioned the spine, so that's one of the things that now enables us to open that up. We've got some things to do on the network. We've got a big program at the moment to upgrade the network. We've just got a new email system. But there's lots of things we've got to do to make our infrastructure across the health and care system apps ready, if you like. And we've got some difficult questions to answer as well about to what extent should these apps access personal health records, to what extent should we or shouldn't we link personal wellbeing data to personal records, and how do we do that in a secure way that's consistent with what the public would expect. So my reason for putting the apps up is to say we've actually got a lot of work to do because our infrastructure isn't yet completely apps ready. But having said all of that, the real question as well as endorsement models and apps-enabled infrastructure is, so what should we or what ought we to do from a workforce perspective to enable this to happen? And this is where you
yeah, and this is very much picks up from Bev's point earlier around it's no, you know, I wasn't sure she's talking around a pantomime horse about the front end and the back end. If we've got the front end of technology, the back end really is the workforce, and you need both of those. And so our role at Health Education England is really to make sure that we have that workforce ready for our new ways of working. I think it's also our ambition of this work stream in particular is to be aware of the contemporary sort of paradigm shift towards a more predictive and preventative approach to healthcare, away from that very traditional and diagnostic and cure paradigm. I think it's really important that we get the workforce of the future ready for that. So to get our ambitions, we consulted with quite a wide range of stakeholders, which we reported back to you on in June. And the 4 ambitions we came up with around professionalism, and I think that's really important. Really, again, going back to this is all about the quality of care, so it's really important to get that standardisation. I think the area that we've really focused on, again, is competency, and that's really what we need to do for the workforce. And that's really aligning our future workforce and our current workforce with our future patients' needs. And again, just to remind colleagues, when we're talking around the workforce, talking around not only the formal workforce, our 1.4 million workforce, which again at Health Education England, we currently workforce plan for 129 different roles, but it's also around that informal workforce. And as we know, we've got 6 million carers and around 3 million volunteers. And it's really important that we look at that as that the boundaries between both formal and informal workforce start to blur. It's really important that we make sure that we have both of those workforces, competencies, to be able to use things like the apps that Andy was rightly talking about. Leadership I won't dwell on at the moment because we're going to talk about that in some depth around the announcement we want to make. And then again on sort of a collaboration, that was our 4th ambition, and that's really where we're trying to again join up, make our both the health and social care work more collectively and both transparently together, and also encourage people to do things differently and do different things across those sectors to be more innovative. So we'll now move on to our final slide on leadership. Which do you want to introduce in our double act?
Oh, in our double act, yeah. So we thought a bit of humour would be required at this point because apparently we've got a bit of a reputation. So we got some quotes about leadership which we thought might amuse or help the discussion. So the first quote I've got, which I really liked, was, "If you make people think they're thinking, they'll love you, but if you make them really think, they'll hate you."
And mine was a bit obvious. Working with Andy, I've learnt that as Groucho Marx said, only 1 man in 1,000 is a leader of men. The other 999 follow women.
And now a serious one, which I think is really quite good, and it does apply actually to what we're talking about today. And it's this: a leader takes people where they want to go, but a great leader takes people where they don't want to go but ought to be, which I think is very apt.
And my final one is from Jack Welch, where he talks about, before you are a leader, success is all about growing yourself, but when you become a leader, success is all about growing others, and that's what we want to do with our leadership, the work that we're doing here. So with that, on the leadership area, on that 3rd ambition that we talked about, the stakeholders really identified that we need to ensure that our leaders do have some digital development. So this really is just to ensure that as we move towards systems of integrated care, as we know from 5-year forward view, that the different models of care are going to change. And we need to make sure that our current and our future leaders of both health and social care are sort of aware of the importance of technology and how that's going to influence the needs of patients in the future. So we've come up with one of our ambitions is to create a series of digital leadership summits. And that's developed, and we're developing those by experts within the health and care sector. And really, that is really for us to help boards, both executives and non-executives, to be more aware of technology and to be more technologically both savvy, but also to enable them to start using that across their organisations. So what we're hoping to do is, or not hoping, what we are doing is we're going to pilot two sessions for health organisations boards. One's likely to be in acute and one other, whether that's mental health trust, community or CCG. And then we're going to pilot those. We're also at the same time having a pilot in parallel in social care, so working with colleagues in social care. And we're then going to, again, importantly, make sure that they are tailored to that context around the digital maturity of that organisation. I think that's really important because I think, as Simon alluded earlier, we've got different areas and working at different levels, and we need to make sure that we, ultimately, our aim is to get a standard and get everybody up to that level. So, in summary, if I hand back to Andy to talk around the outcomes of this, our aim is to ensure that leaders, that we develop leaders, and so that they can develop a culture within both health and social care organisations to use technology to really sustain high-quality care and also the ever-improving care for patients. So that's our goal with these summits.
Thanks, Nikki. And just one other thing before I briefly talk about, so what are we trying to achieve with these summits? One of the reasons I think this workstream is so important is that if we're going to achieve a digital revolution in health and care, it means that all 2.5 million people that are either directly or indirectly employed ultimately have to be making it happen, not the people in this room. And that's really what this programme is all about. And well, it is about how you use the technology, and for a lot of people it'll be how you use the technology, but it's also, how do you develop things like the Mersey Burns app, and how do you make them generally available? And the reason we wanted to start with the leadership, well, a couple of reasons really. One, leadership starts with leadership, but also to link in with Paul's, the initiative that Paul talked about, where each of the local health economies are going to be asked to develop their digital roadmaps, if you like. And so this is working hand in hand with those. So these are targeted at the leadership teams of the organisations that are being asked to do that. And so the outcomes that we'd be looking for are partly it's about education. So we want to bring some exciting outside speakers in from health, but also from other industries about digital journeys they've been on. So a little bit about education on the art of the possible, but more importantly, to develop a plan for that particular board. And when I say board, it's the non-executives and the executive teams on the leadership teams of organisations, trusts, etc. For them to develop a plan to improve their understanding of the technology and the data, or the digital agenda. And secondly, to develop a plan to make some improvements to that agenda, so to raise awareness generally as Paul's documents start hitting them. So with that.
Okay, thank you very much. And we're now moving from the delivery updates that have come out of the individual work streams to look at a piece of work that Tim Donahoe, Beverly Bryant are leading, working with HSCIC, Peter Counter specifically in HSCIC, to assess the portfolio and to look at the proposals that are coming out of the work stream roadmap. So I'll hand over to Tim.
Is having a good understanding of what the costs and the benefits and the potential value and the delivery confidence of all those activities is. The second phase is really then about assessing, what we would want to do, and I'll talk a little bit more about that in a second. But then the third phase is where we get to a critical discussion about what the priorities are and what we can afford to do. So let me talk through in a bit more detail the first phase. So Over the last few weeks, we've been working with colleagues to collect data on the current activities, and given the volume of activity that's already underway, that's been quite a challenging process. What we need to do is ensure that we have a full understanding of what each programme or service that's currently underway is actually contributing. How much does it cost? When is it going to deliver? Do we think it will deliver? And crucially, who owns it and whether or not it's aligned to one of the strategic outcomes that we're seeking. Because in some cases, activities that have been underway for a number of years, may not be strictly relevant to the current context. But for this group, I think the more critical work is really what we're doing around defining the candidate programmes, and that again is very much about doing that same kind of analysis. What are the outcomes that we're seeking from this work, and how do we group together the activities that the work streams have come up with in logical groups that become deliverable and can be taken forward as programmes. Our current thinking is that there are between 25 and 30 candidate programmes. The reason that number keeps changing is because as we get to understand in more detail what each of the work streams have been intending, it becomes more obvious how some of these things might fit together going forward. So really what we aim to do by the end of September is get to what we think the target portfolio should be. And by portfolio, I'm talking about all the activities that we would want to take forward. And we get to that really through the assessment phase, which essentially means looking at the ideal set of things, both old and new, that we would want to take forward in order to achieve all the outcomes that we're seeking from personalised health and care. So in this phase in particular, we'll be looking at eliminating duplication, overlap or redundancy, things that are no longer needed. Absolutely critically, making sure that all activities, both the new proposals and the existing ones, are aligned to one of the strategic domains that Rebecca showed the slide for earlier. And then that gives us our target. Now, at the moment, we're aiming to finish this by the end of September, but that could slip slightly depending on how our analysis goes over the next week or two. We then get to the hard business of prioritisation, and I'll talk a little bit more about this on the next slide. But I mean, what we're essentially trying to do here is look at what can be taken forward, what can we afford to do as we come to understand what allocation of funding we've got through the spending review. So it's absolutely incumbent upon this work stream to make the case for all the other work streams in terms of what needs to be taken forward. So sorry, I was out of step with the slide. So the spending review is running to a late November timetable, so that's broadly the timetable we're working to, and that's likely to be an iterative process as we have discussions with the work streams, with the leadership team and so forth, and ministers around what we think the priorities are. And as we get better sight of the available funding, that will give us an indication of the degree of difficulty in terms of the decision making. Almost getting to a point of if we could only do, the top half dozen things, what would they be? When you look at them from the point of view of modernisation of patient experience, improvement in clinical outcomes, reduction in expenditure, etc., etc. So, however we cut it, we want to have all that information to hand so that we can make the best possible decision that gives both value for money for the taxpayer, but gives us the strategic outcomes to the extent that that's possible. But this isn't just about the spending review. We have to plan with confidence for delivery, and as we sort of move through the next phase and get through that prioritisation discussion, we need to start thinking about what the governance model is to go forward, and do we start to organise these programmes around the strategic outcomes. So, there's an important discussion to be had about the future governance model here. And we need to start the detailed planning for the programmes that we think will need to be mobilised, so people taking ownership of those, starting to do the detailed planning that will enable them to go forward, and also thinking about decommissioning the things that are no longer needed. Before I hand over to Beverly to talk about the emerging programmes, I just wanted to provide a degree, hopefully, of reassurance. I think it's very easy, and this has been apparent in our discussions with the work streams and others, stakeholders, it's very easy to get the impression that, you know, on one level this is about delivering a bunch of new IT projects, and whilst the IT is critical to the transformation that we're trying to achieve, I want to emphasise the degree to which we're trying to ensure that we remain aligned to the outcomes. And what we're actually seeking is the most efficient route to any of the outcomes. If that's a locally driven project or a locally driven set of activities, then that's what we should be doing. If we think it should be done once from the centre, and if it's a big IT project, then that's what we should be doing. If it's a digital approach to developing apps or so forth, you know. So this is absolutely about learning some of the lessons of the past, avoiding, you know, focusing unduly on the projects as ends in themselves, and trying as far as possible to minimise development, minimise interdependencies between the activities, because then, you know, we guarantee that across the board things are more likely to succeed if they're not too tightly coupled. And again, the last point on there around clear ownership of outcomes, I think is absolutely critical, because unless somebody actually feels the responsibility of delivering each of these outcomes rather than the individual projects, then you know, we will make success very much harder. We're not quite at the point yet where we're thinking in detail about how we do each of these programmes, although Beverly might say a few words about this. But we are thinking about, for example, you know, whether we do things that are quite limited in scope but big in terms of demonstrating what's possible. So, you know, individual organisations or health economies or CCGs, you know, doing exemplar projects, you know, where they have an existing good level of digital maturity. And looking, when we think about maybe funding local activity and the digital roadmaps and so on, thinking about a something for something model where the funding is tied to delivery of the outcome, not delivery of an output in terms of, you know, buying a new system, and incentivising people to drive the activity and the transformation. I'll hand over to Beverly at this point, and she will take you through some of the emerging thoughts on the new programmes.
Thanks, Tim. I mean, Tim's covered all the principles that we've applied in pulling this work together. I think the only other thing we've done, we've had external support to help us validate the costs, to make sure that they're not just decided by us as a group, they're actually sometimes internationally validated by other countries who've actually gone on this journey themselves. But we've also tried to create a language and a narrative that our teams, will understand. What we don't want to do is have a new set of candidate programmes and we spend the next 3 months all trying to explain to each other what we mean by them. So there's been an element of taking language and ways of working that we already have, just so we can get some momentum on delivery. So to get into the right outcomes, to bring this alive a bit, we've got 20, at the moment, 26, even since I've done these slides, they've gone down to 25. As Tim says, we're merging, we're changing, we're trying to create scope of programmes that can be costed. Okay, so that when we put our spending review bid in, we can explain what we want to do, we can make sure the money we're getting for it is internationally validated, but then there'll be so much more work to do to actually flesh out the detail, the timescales, etc. But we've had a real good go at bringing that alive. So I'll just pick out a couple of examples. We've also tried to focus on deployment, change and transformation, as opposed to enablers, getting the technology set up. There's two sides of the same coin, but we've tried to separate those out. So, for example, digital primary care, which might be on that slide and it might be on another slide, is about taking enablers and getting the primary care community to use them. So it's about uptake, bringing the workforce with us, having change programmes that allow our primary care colleagues to move forward in offering access to records, telehealth apps, etc., etc. But there's also a technology programme that's remote, I can't find it, remote consultations, telehealth, etc., which is actually setting up the commercial and technical framework so that GPs and primary care colleagues don't all, 7,900 practices, go to PC World to buy the technology. because nationally it's more efficient for us to actually get economies of scale on costing. So that's one example. Innovative uses of data that pulls out the ambitions from 2.2 really goes into exactly what needs to happen to really bring data alive. But it has to be underpinned by a data services platform. So a data services platform is one of the programmes that needs to be delivered before we can start to really come alive. So the next stage over the next few weeks is to start to lay out an overall roadmap, say that we must get started on that before we get started on that because of the interdependencies. So, and the other point to make is that we've really kicked the tyres of local versus national. We've been really honest and open through our NIB that we've really got to make sure that this is owned by the front line. There's a lot of local delivery going on. But we might also need to do some things nationally. We've said today in our launch of our local digital roadmaps that CCG's health economies will be responsible for achieving paper-free at the point of care. But funding, if we are successful in achieving funding for that, we will still want some national role in maybe allocating the funds, testing benefits and just making sure. So we're not, and local doesn't mean just totally toss it out to local and do nothing nationally. It's about getting that balance right. So I'll end there. Thank you.
Great. Thank you very much. Look, this has been a really long session, but it's been very, very important because the next 2 months kind of will determine the quality of the work that's going on here, will determine the degree to which we can actually afford to implement the outcomes that we've all agreed in the framework. So I'm sorry if that sort of was rather being spoken to for quite a long time, but it's just important that everybody is aware of what's going on. So look, we have time for a few questions now before we get on to some of the closing points of the meeting. If people want, or comments, people want to raise them, we will then, of course, move into the public session where, again, we can have a discussion around the broad themes. So I don't know if people just briefly do want to raise any comments or... Yeah.
I just think one of the challenges that we may want to reflect on ourselves is whether we are involving patients, citizens and users at the right level. So within the framework, we talk a lot about co-development. I think within the work streams, we're seeing elements of it, but one of the questions that I still have is, across the work streams and at the national level, are we getting co-development right, or are we actually going on and just consulting people about views and visions that we've set up? So really a kind of thought and reflection for what we may need to do, because fundamentally we will need to get to the point where we are bringing patients along with us, and it feels slightly, to be honest with you, as if there are afterthought in some of our areas, and we will need to address that, because if we can't do that and we're making things work for clinicians, we're making things work for the system, actually we won't bring patients along with us and they won't buy into it. So just a reflection.
Yeah. I mean, I look at that, such an important point, and it is one of the fundamental principles of the... And to be absolutely honest, and you know, obviously, please do spend time with the workstream leads and with other colleagues, because actually there's been an awful lot of work in relation to the work streams and the roadmaps co-production. There's obviously we should be doing more, but you're absolutely right to keep us honest at this point, because this is the moment where we start turning the priorities into actual programmes, and it's absolutely essential that we do that in a fully co-produced kind of way. So thank you. Yeah, Sam.
We've had a number of presentations about how many people have had discussions, public meetings, specialist meetings, and following on from this point. There's very little clarity in what new things were learnt that wasn't seen as important before, or things that were considered as we might do this before, which aren't going forward because of lack of interest or duplication. And it sort of seems from the slides that for certain bits of this, the process might be doing what the process was going to do, even if those meetings haven't taken place. And I think, you know, that's probably not true in a bunch of cases, but can there be a lot more clarity as to, you know, what the effect of the conversations and discussions have been?
Okay. Good point. Yeah.
Ian Trenholm, NHSBT. A number of people today have talked about apps and the development of apps, and I'm just thinking that the Government Digital Service have effectively banned apps across government because they were concerned about a proliferation of different apps that the public couldn't get to and internal users couldn't get to. do we need to do a piece of work on aggregating apps in a way that that the public can get to and we can get to internally? So, for example, the Burns application is easy to see for a new A&E doctor, with all of the other apps that are being developed, both with the people in the room, but also by suppliers who are, again, supplying multiple apps, so that they just become very easy to use. 'Cause my sense is there isn't necessarily an apps policy that's very clear and an aggregation engine for them.
Well, actually, Liam Maxwell is a member of this group, and he sent his personally, he was very upset not to be here today, because, as you know, GDS is obviously reflecting on its own sort of strategic objectives. But I think your point is really well taken, and I think actually I'm unaware of a government quotes apps policy, but
exactly right. And I think that is one of the, I think, and that is watching, you can correct me if I'm wrong, but that's part of the engagement endorsement sort of work stream, which is to work out how we do that. I'm not sure actually.
There is a GDS policy on apps, and basically you are not allowed to, if you're a government department, you can't build an app unless you should go on gov.uk as a piece of functionality within gov.uk. So it in practical terms is a ban on apps, and you have to
well, a ban on building
apps. Ban on building apps.
Yeah, yeah. which we kind. I mean, yes, that is true.
To be clear, I'm not proposing that. All I'm saying is I think we just need to have some standards and some way of aggregating the apps so that they're a bit more visible. Because I think a number of people have made the point that getting traction around usage of apps is quite difficult, and that's arguably because people are just rootling around the app store to get them.
Any other quick points? Sorry for rather a truncated discussion, but okay. Well, look, let's move on then, and we can pick up some of these points in the discussion afterwards. Can I just invite Alex Caffett to come and briefly describe the annual prospectus? One point of decision for the board to make today is that you are happy with the proposals for publications prospectus. It's still in draft form, so we would welcome your comments, and I think the plan as we're here now is to publish it at the end of September, but we do need your permission to go ahead with that. So if Alex can just introduce that would be great.
Thank you, Tim. I'm going to do a double act with Helen Arthur, who's done most of the work on this. I was really pleased when Tim asked me to take a watching brief on how the NIB might report publicly, because I think we all realise it's really important, and this is echoed in some of the stuff I think Beverly and others have said, that we need to be able to show the impact that we're making since this framework's been published. And yesterday, in the Pop-Up University, I facilitated a session where 45 patients, carers and members of the public decided not to go and hear the Secretary of State, but in fact come to a workshop in the Pop-Up University where they fed back to us some of their thoughts around the work the NIB is doing in the first half, and then we preempted the consultation, and they gave us some thoughts on the role of the National Data Guardian. And what that showed is that, with a fairly small sample size, there was a real appetite from those people who all knew about the National Information Board to find out exactly what we're doing. And this prospectus is the first time that we're going to go publicly and kind of consolidated and come out and say that. Board members will recall that they approved the plans at the last session at the King's Fund, and that there was three kind of big aims to the prospectus, which are on the slide, which was to report on the framework, as I've just said. The Secretary of State has tasked us to report on the My NHS website and the transparency agenda more generally, and it's also to take stock of the role of the board and you know, to keep it evolving and to keep it relevant. So since you all approved that, Helen's gone away and done a lot of work, which is in the papers, which she'll talk through. I wanted to just quickly just talk through the people we've kind of spoken to since the last meeting. So we've had further input, and we thank the Richmond Group of Charities and our colleagues at Macmillan who've been coordinating that. The localities and community part of the Department of Health have given us some input. my colleagues, the other independent members, have also come back with further comments. And I think importantly, we've kind of had some fairly formal conversations with the National Quality Board, the Strategic Clinical Reference Group, and NHS Citizen, how they might help kind of, check what we're doing and make sure that, first of all, it aligns with them, but second of all, that, we're not marking our own homework and saying the NIB is fantastic, we've achieved everything we're going to set out. So we thank those people. Also, just quickly, we benefited from a Department of Health intern. So Ashley's in the room somewhere, but we just wanted to thank her because she's done most of the work on putting this together. So that's really kind of the stuff that I've been doing as an independent member, and I'll hand over to Helen, who's going to kind of go into the detail of what the team's produced.
Thanks for that, Alex. So I'm not proposing to talk to you at length about the content, but I just wanted to give you an overview of the structure and the format, and invite comments and questions. So the way we've shaped the document in terms of trying to make it easily accessible and understandable to a wider audience is by splitting it into a series of phases which reflect the journey that we've been on collectively over the last 18 months. Each of those phases has some significant milestones which you'll all recognise, such as the establishment of the NIB, the publication of Personalised Health and Care 2020, and the development of the roadmaps. It also covers a lot of the engagement that we've gone on and the people that we've brought with us along the way and have helped shape where we've got to. There's a section at the end of this report which really looks at what happens next for the NIB, and obviously there's a lot of question marks still there, and we're working through those. So the content will be developing over the coming months. So just in terms of the format of it, we're looking to digitise health and social care, so obviously we need to reflect that in the way that we're communicating, and it will be a digital document published on gov.uk. The idea is that it's very interactive with lots of links and signposting to other areas of best practice and things that we can learn from. One of the pieces of feedback that we've collected over the summer months when we've been doing a lot of wider engagement is that there's a lot of information everywhere on what is good practice and what case studies of different localities have been developing, and that actually it would be useful for the NIB to signpost to those. And that's using that feedback. We're hoping to keep the document developing between its publication at the end of September and the publication of the annual report in March. So that we're not static, we're actually able to use this as a launch area as well. So just coming on to metrics quickly, it's just quite important to note that this isn't necessarily looking at how well we're delivering programmes or specific outputs, but it's looking about how we're delivering our purpose, all the things that we've committed to over the course of the last 18 months in the development of terms of reference and membership. The next few slides, I'm just going to flick through quite quickly because they're just giving you a flavour of how it will look. I'm not sure how well you can see this on their screen. It's probably slightly easier at the back, but the papers are in the packs that were sent out to you all. So you can just see a little bit there about how it's shaping up and how you'll be able to navigate. We're at quite a tight deadline now to get it published for the end of September. And as Alex mentioned, a lot of you have already been involved, and we're incredibly grateful for all the feedback that you've given us. And if anyone would like to be involved further, we've got about 10 days to finalise the content, and would very much like to invite anybody who is able and willing to be involved in the review to make themselves known, and just contact us by email, and we'll be happy to discuss. But yes, so the plan is to finalise all content by the 18th of September for publication at the end of the month. Thanks.
Great. Well, thank you very much, Helen. I hope people have had a chance to look at the documents in their pack. I think it's a really great piece of work. It I hope, will set a kind of slightly new standard for accessible information in this public service as well. So we've worked hard on that side of it too. But anyway, feedback would be gratefully received, particularly from colleagues at Healthwatch and elsewhere. So, but if people could move quickly with that, that would be great. So, mindful of time, I'm just going to invite Will Cavendish to give his response as the departmental official responsible for delivery of these programmes to what we've all
So
heard.
thanks very much for that, Tim, and thanks very much for everybody today for their presentations and their work. As you mentioned right at the beginning, Tim, I mean, the department under the wise leadership of Una set up the National Information Board to play that strategic role in understanding and setting sort of priorities for data, technology and digital, being the board which for us leads on this critical digital transformation. And I was touched by the use of quotes earlier. And if I was going to encapsulate what the working feels like to me in one quote, it would be Muhammad Ali when he was in a drizzly night in Zaire doing an extended press conference, and journalists badgered him and said, Ali, Muhammad Ali, give us a poem. And he said, me, we. And that feels like the way in which the work of the National Information Board has evolved over the last year, away from me, individual organisations, individuals working in silos, towards system working, genuinely confronting some of the challenges that we face in this area, not ducking them by sort of cosy consensus, but actually digging into them, but getting the benefits of working across different organisations. So for me, so often in complex systems like health and care, boards can be places where endless discussions happen, or they can be places where action is taken and energy is driven. And the National Information Board for me is the latter, not just because of the charismatic and energetic nature of its chair, although that helps, but I think because of the enormous commitment of time and energy people have put into it. And what we've heard today and what you see in the expo is that progress happening. That said, I think it's important if I try and provide some sort of wider canvas of things that are happening in government and in the department, and almost invite and indeed continue to challenge the National Information Board in connecting up to those wider opportunities. So within government at the moment, there is an enormous emphasis and focus on digital as an agent of transformation. And whether it's in the Revenue and Customs Service, or whether it's in benefits and pensions, whether it's in government as a platform, there is an enormous focus over this next period of time, including in this spending review, in how we really harness the opportunity of digital to provide better services at lower cost, and indeed how we make the digital economy, including the digital health economy, an enormous win for the United Kingdom. And that is something which the National Information Board should and needs to connect up to, those broader currents happening in government. Equally, within the department and within the sort of macro world of health, I think there are 4 or 5 areas, sort of challenges, where the National Information Board can and should play a significant role. The first is really picking up the point that many people have talked today about not seeing data, technology, digital as an end in itself, but seeing it as part of the enabler or the agent of transformation for better care, safer care at lower cost, and connecting up to the really powerful challenges that we face now and the next 5 and 10 years, and ensuring that our work on data and technology and digital are part of that. So, for example, how we make our hospitals safer and more affordable, how we transform our primary care, how we develop integrated care and much, much stronger out-of-hospital care, how we ensure that our clinicians feel that technology and data supports them in their daily work. It's something that helps them do their work better, helps them look after their patients in a better way. Now, we made a start on that in the National Information Board by, in June, identifying some of these big priorities. And I think Rebecca put up the sort of domains, the helping individuals make better choices, transforming general practice, and so on. And it's really vital that we continue to ensure that our work and the opportunity of technology and digital is embedded really fully in those absolutely crucial health and care ambitions, so that going forward, we never make the mistake of technology and digital being seen as a sort of thing that happens in the sub-basement or happens with a bunch of IT projects. This is front and centre to change and transformation and improvement in care. And that's really a real challenge for us, I think, and for the National Information Board. The second is intelligent transparency. Now, the Secretary of State has given a couple of what he regards as landmark speeches on intelligent transparency. And by it, he doesn't mean transparency is a thin window through which you look at some stuff. He means a cultural transformation in health and care, towards a system that is open, is clear about its outcomes, learns and empowers patients. And again, that is an enormous opportunity for the work of the National Information Board to connect up to a very powerful cultural change that's being undertaken in the health service. A couple of weeks ago, I went to Queen's Hospital in Romford, and I went to the radiology department to see their work. The first of the meeting was, of course, taken up with them saying they needed a large bid for extra machines. I'll pick that up with you in a moment, Una, naturally. But the other half of it was about their frustration at being unable to know how good their service was versus the other services in local hospitals, other local hospitals in London and indeed up and down the country. They were hungry for the data on outcomes that allowed them to know where they were good, where they were bad, what they were achieving in terms of cancer outcomes in particular, and how they could actually then learn from each other, or indeed how they could be proud if they were one of the best organisations. And they were looking forward hugely to the publication next year of the cancer registries and the cancer data that's being very carefully collected. Now, the power of that, the change that's taking place in health and care towards openness about outcomes, about transparency about outcomes, and the ability to learn and to share is an enormous thing. I think, again, there's an opportunity for us to lift ourselves up from the enormously important work of the National Information Board into that area. The third we've touched on already, which is the vital importance of trust, cyber security, information security. As we open up and as we digitise so much stuff, so this needs to become much, much more important. And to be honest, virtually, it used to be not a week goes by, now it's virtually not a days go by without stories of hacking, data leaks, inadvertent data sharing. And this absolutely erodes the fundamental sort of trust that underpins the work that we do. So it's a hugely important priority. The fourth, which just picks up something that George Freeman said, is to be honest, a kind of ministerial but also a public demand for stuff happening a bit quicker. So the experience people have in other bits of their life of being able to use services, being able to do stuff for themselves and their families in an easy, accessible way. The sort of constant demand, when are we going to see that? When's it going to happen in health? So we need to make sure that we are doing that effectively and well, and sometimes providing ministerial leadership with those examples of the changing service that the public notice quickly. And then finally, the crucial thing at the moment, which Tim and Beverly were presenting on, was making sure we secure the resources within the public sector that provide the investments that will underpin this work for the next 3 to 5 years. And Tim and Beverly have presented on that. But just to emphasise the importance of that, ensuring that we have sustained, like many other organisations, sustained and decent investment in these capabilities, in this technology, so that we can support the changes that the National Information Board has laid out in Personal Health and Care 2020. And some of that will involve some prioritisation. We probably won't be able to do everything. And we'll need to make sure that the really core things are done and done systematically. So we do need to make sure by 2018 that every single care setting is using some form of an electronic record, patient record or health record, whichever terminology you prefer, that has embedded in it the standards which allow data sharing, record sharing to happen. We're able to ensure that staff, when a patient or a user rocks up in front of them, can easily access that. That is a core platform, the universal electronic record on which so much else is based. So we're going to have to sort of prioritise as we go through, but that's a vital piece of work for the next period of time. So I'm sort of looking to the National Information Board and indeed to the National Information Board Secretariat to be thinking and working on how the incredibly important work, and it's virtually impossible to keep up with it because there's so much of it going on, how it really can land and be secured within those critically important priorities going forward. Just finally, I think there's a sort of sense for some of us that the National Information Board is at a bit of a cusp at the moment, and that we've had this very, very important work underway in Personal Health and Care 2020, culminating in this critical work to try and secure resources for the next period of time. And maybe it's the time then to think about the next phase of work for the National Information board, part because some of this stuff, once it gets funded, will move more into sort of regular delivery and the sort of regular structure of programme and performance management and oversight and delivery, partly because the board has been set up to continue to think big about the data, technology, information challenges that are facing health and care, and is the organisation we want to see grapple with those. So, things like the emergence of genomics, of personalised information, stratified medicine, and so on and so forth, the technology, the opportunity, but also the ethics around that. That is a big piece of sort of thinking work that still needs to be done. The National Information Board is very well set to be the sort of place that takes that kind of challenge on. Big data, we've talked about it in Personal Health and Care 2020, but of course, and we've got a certain distance, but it's going to be an enormous opportunity and challenge, going forward. There's I think, a role for the National Information Board in really digging into and thinking about how that's going to work and how it can be taken forward. Truly empowered patients. Truly empowered patients that once we've given them the data and the technology and so on, actually take control of their lives, control of their healthcare, able to look after their families a different way. By the way, not just in their location, but my wife's aunt in Jamaica, who would love to be able to look after through remote means and technology. Everybody has a story of this. This is going to be global, not just local. National Information Board is our place for thinking some of these big challenges through and working out how we respond to them and how we set priorities here in health and the UK health and care system, or the English health and care system. So alongside that, the importance that the board can play in connecting into these really big government-wide opportunities and challenges, and indeed health-wide opportunities and challenges, I think it's quite a good time to start thinking about the next phase of the National Information Board's work, the big issues that remain around information, data, technology, ethics, and the work programme for this board in helping the whole health and social care system, and as part of it, the department, try and prioritise and think through some of these problems, drawing on the immense expertise and energy that's been pulled together through this organisation.
Well, thank you very much, Will. And I think that your challenge is really helpful, and we absolutely must collectively work out how we deal with those big issues. Just before we move into the next session, though, I just wondered if Una has any reflections.
Not many.
Okay.
We're ready for lunch, I think. Yeah. Thank you very much, Tim, and what a fantastic array of presentations. And I know it's been, if you like, download heavy today, but I think we've all needed to hear that summary of what each other is doing at this critical moment. The spending review is really, really important, and the discussions will be going on throughout September and October, and we expect to have the output of that by the end of November. So I see all of this developmental work on reforming the programmes, designing the the roadmaps and the local indices, absolutely fundamental to come together with that new resource envelope for the next 4 to 5 years. Now, I just want to round up by, as well as congratulating everybody on the work to date. When I spoke at the end of the last meeting in June, I talked about resilience, and I talked about the resilience that we would need as a group to keep going through all the challenges that would come our way. And I wanted to pick up momentarily a slightly different theme for this morning, and that theme is how do we deliver change in complex systems? And there's a huge amount of research on this, and I think that as we go forward with all of the detailed stuff and the energy that we have for what these changes can deliver for patients, we need to also have that sixth sense. So are we going about change in the best possible way for the types of things we're trying to achieve? So I've made myself a little scorecard, seeing as they're in vogue, as to how I think we're doing. And the things that strike me particularly are, first of all, you have to have one true north and some clear goals. How are we doing on that? Actually, I think we're doing pretty well. We had the strategy, we've got the clarity of goals. If I had anything to say is we've got to be careful we don't make too many goals
or have goals that cancel each other out. We've got to be able, every single one of us, wherever we go in the country, to just trot out in 2 or 3 sentences, this is the overall aim and these are our goals. And that clarity is absolutely fundamental to delivery. Secondly, what's our level of engagement and dialogue with the people who do this work and use these, are going to benefit from all the changes we seek to make? Now, we had an interesting thing happen this morning. So we had lots of reference to the effort that's gone on over the last 3 months on engagement. But quite rightly, one of our participants here said, well, are we sharing enough between us about what that's producing? And are we really listening to what people are saying, or are we doing it so that we can tick the box and say we had X number of meetings? Now, I don't think it is the latter. I think we are listening. But I think it's very important to the process of change that we are smart enough to pick up the messages that matter from that dialogue and that we keep doing it. My third one of 4 is you have to, and this is a phrase that's used quite a lot in the research about complex, delivering change in a complex system. It's called give the work away. And what that means is, are we getting the work done at the right level? I am very encouraged by this approach now to having the digital roadmap locally and the digital maturity index, because that way we're able to answer that question much better. Are we giving the work away to the right level? But also, crucially, are we pulling back into the centre that which needs to be done centrally to help the work to be delivered locally? And we have to realise that that's a dynamic thing. It's not a once and for all answer. But giving the work away to the right level is critical. And then the fourth one is, when we've done all that, are we smart enough to make the adaptations to the way we're going about our work that we don't get? Now, this, if you like, the big lesson from Connecting for Health was that people became very, very stuck in the programme infrastructure and the things they'd set out to do, and the years ticked by and they were still clinging on to that thing. Now, the smart thing is to be able to let stuff go. So I was very encouraged by Tim raising, what are we going to close down? What do we no longer need? Are we able to set fresh priorities? So I think if we can sort of have that type of mindset around how do you deliver change in complex systems as a reference point for validating our method, I think that would be a good thing. And finally, I just want to say I'm a great believer in everybody putting their hand up and saying what they're going to do next. So the thing that's got me this morning are the digital leadership summits. So I think that's really exciting, and I'm planning to come to one as soon as I find out where they are. So thank you very much for a great morning.
Great. Well, thank you very much, Una. Right, now, lunch, you don't get lunch yet, because we're now going to, I think, I'm not quite sure of the arrangements, Rebecca, but we're now going to enter into our public session, which Joe is going to chair for us. So obviously it's not mandatory, but if people want to stay, that would be great. Are we going to turn around a bit?
Yeah.
Okay.
Well, so I was just going to just a couple of minutes to explain how we're going to run this session, and then, in fact, ask people to stand up. I'm kind of conscious of people are now saying that sitting is the new smoking, and we've all, I think, been sat here for at least 2.5 hours. So anyway, so we will have a chance for a bit of activity. But anyway, the next, I think, about 35 minutes are a chance for some dialogue between members of the National Information Board and the public, who are both here in the room and also have been listening to what's going on through the live stream and on Twitter and so on. We thought it was a chance to have dialogue, so that is both a chance for the public to ask questions of members of the board, but also I think there's a really useful opportunity here for members of the board to hear some of the experiences, aspirations, concerns that those of you that are out there kind of encountering some of these systems and wanting to use the information technology are experiencing, and a chance to share that. What I was going to do when we kind of actually get into the question session is ask people to say who they are, ask questions, stick to questions, and the bit that we're doing on questions, we'll split the time between first taking questions and then taking more sort of comments and feedback. So when we're doing the question session, please stick to questions. Please say who you are. And I'll take the questions in groups and then kind of going to direct them as best we can to people on the information board. But what would be really helpful is if those of you, if you know you are the person who knows the answer to that question, please, do volunteer it rather than waiting for us to work out who it is. Okay. I hope that's clear. So what I'm going to suggest is everybody stand up, even if you're not changing around. It's a chance to stand up, stretch. Very good. And then people, who are on the tables, please do turn your chairs around. I'm going to go down to the middle of the room to sort of chair this next bit.
And while Joe's just doing that, can I just remind everyone, as I formally close the meeting, which I didn't do, that the date of the next Leadership Summit is on the 8th of December, at which all these programmes will finally be funded. Thank you.
It's number 2. Oh, sorry. This one? Is this one on? Yeah. Okay. Thank you. Great. Okay. Well, I hope everybody who wanted to had a chance for a stretch. So we're going to start off, as I say, with a chance for questions to members of the board. So we have been having questions coming through on Twitter. So we have got questions that we can, or I will put to them on behalf of the people who sent them through. But I thought I'd start just with people in the room. So if anybody does have a question they would like to ask, we've got mics. So please put your hand up and we'll take them from the room first. Yeah, over there. I'm not sure. I don't think we can hear that. So if you...
Yeah, Malcolm Teague from GS Glasgow, which is a charity, which is the UK's research and education and research network operator. In terms of the moving to prioritisation and implementation that was discussed, I just wondered if you could just explain, perhaps, just take an example that is particularly of interest to us, and that is the ambition to have the NHS estate as have free wireless on the NHS estate. And I just wondered how that, could you perhaps take us through how that is being thought of in the process of prioritisation and implementation?
Right. Okay, well, we'll, as I said, see if there's any other questions to take together. So that's great, very specific question. Other questions from people in the room? Yeah, here. Thank you.
I'm actually going to speak as a member of the public, but also representing the Richmond Group Charities, even though I might be on the board. Sorry. It was really interesting to look at the Oxygen app, and it looks, incredibly helpful for those who work on the ground. But by nature, it is a mobile app, and therefore runs the risk of data being left on the train or left at home, or however you want to say it. So I think it's just a question about what's the issue, how can you assure us about the security of that data on those apps, but also the way that it works in the background. I'm not sure how secure fingerprint technology is on the iPads, whether it can be broken, but I think there's certainly a question for us about how can patients be assured that their information is actually going to be secure on mobile apps.
I'll pick up the Oxygen point. So there's no patient data left on the device. So there's no patient data stored on the device at all. The only data that's stored on is user credentials, and that's encrypted. But there's no patient data on the device.
Okay, so great. That was a straightforward answer. Going back to the previous question then on talking through the process of prioritisation of Beverly, do you want to answer that?
In terms of So Beverly Bryant, Director of Digital Technology. The question was about the funding of the Wi-Fi.
Yeah.
So we've looked at this. There's loads of ways in which we can fund Wi-Fi across the premises, across the NHS. There are self-funding models, but at the moment they're not well enough developed. For example,
letting somebody log in and then have adverts fly. You know, we're nervous about somebody putting advertising on a website that could allow, you know, you sitting in A&E on Wi-Fi being given adverts from Tesco for special brew, or whilst, you know, so it's not appropriate to do that. So what we've done is we've taken a cost, an industry cost for all the GP practices in the country, and what we've looked at examples of how much it's cost for a hospital trust to roll out Wi-Fi. And we've rolled that up into our cost estimates that have gone into our spending review priorities. Now, when it comes to what we get at the end of the process, we might then need to look at other funding models, but we felt at this stage, to achieve that ambition, we need to be realistic about what it's going to cost to do it.
Okay, great. Matt wanted to come back on the previous question.
Yeah, we heard about oxygen, and that's how I figured it would run, which is fine from a point of view of data security, and that's how, personally, I would like to see a lot of apps being run. But you are right, devices can be hacked very easily. There was a case last year where someone took a photograph with a very good Canon camera, and from that took the person's fingerprint and unlocked their iPad. And that was just to prove a point. The problem I think we've got is actually not so much about people's data leaking. It's more about an education of people understanding what data is already leaked already and what data they are leaking every day. And as soon as you start explaining that to people about what they're giving out already, people may start withdrawing from Facebook or other such things, or they may just go, oh, okay. I can run a free app right now on my phone, which will tell me anyone in this room who's got their mobile phone with their Wi-Fi signal on. It'll tell me where, and it's free and it's legal, it'll tell me where you have used that phone before on a Wi-Fi signal, and then there is a free map, an international map, which is permanently being logged, shows me where all those Wi-Fi codes are. So it's very, very easy to pick up lots of information that we don't know we're permanently just handing out. So for me, the big thing is about actually encouraging the education of understanding what you're giving out, and then you can have the conversation, is that really an issue? Because most of the time it's not.
Okay, thank you for that. Anything further you'd like to say in response to that? Are you happy with those?
No, I think that's great, fantastic. I mean, we'll probably pick up some detailed bits with HSCIC, but for now that's really good, thank you.
Okay. Right, I thought I'll go to some of the questions on these cards that have been written that have come on through Twitter. There's two that relate to the spending round, so I'll just read these together. So the first question was from, well, at Clark Mike, so I guess that's Mike Clark. Is there a detailed Health 2020 submission for spending review deadline on the 4th of September as part of the 22 billion savings? So I guess that's asking about the contribution digital's making to the savings. And then the other question that I think is related, so if we take them together, is will the digital health savings identified in the spending review be broken down and added to local digital roadmaps? So I think something about then how savings are going to be allocated. Yeah, also from at Clark Mike. So, Will, were you going to answer that?
Sure. So, I mean, like all departments, the department is submitting on the 4th of September its account of its priorities and its funding needs, spending sort of needs to the Treasury for this next spending review period. I mean, people will understand why we can't. I mean, I'm not going to be able to tell you or reveal sort of chapter and verse of each element of that. But suffice it to say that the work that Tim and Beverly have been doing with the whole sort of NIB work streams on understanding what the technology and data priorities are and to trying to cost those forms the basis of that component of the department's submission. That is the beginning, as Una mentioned earlier. That there is then a process of negotiation, consideration, challenge, and scepticism, I suppose, from the Treasury to all departments. That will include us, which will, transpire by November, late November time in a set of settlements for the departments, and we will then need to take that back into well, what does that mean for what we can do, what we can prioritise, and also what does that mean for what central funding that sits whether in the department or in arm's length bodies nationally, and what local funding or demands are there. So that's what we're going to need to go through. Obviously, given where we are in the process, I can't say too much more than that. But suffice it to say that this Friday, the department will be submitting that, and the technology and data work that is being talked about here will be a significant part of it.
And anything you can say on the local digital health maps and how the savings might be, whether they will be devolved?
Well, Paul, do you want to get that point particularly?
Yeah. So I think two things back to Mike, know him and love him. One, I think he's got a little bit ahead of himself in terms of that bit of his challenge. But one of the things that we are very clear on is that there are benefits to be realised from this investment, but ensuring that local organisations in any of their proposals pay an equal amount or more attention to articulating and focusing on those benefits going forward is a really critical thing. It's one of the lessons looking back over the last decade of investment, is that the NHS has not applied itself to identifying and capturing and articulating the benefits clearly. So I definitely think that will be some aspect of the ambition around the roadmaps going forward, and we need to help and support people do that well. So that would be my response on that.
Right, okay. Any more questions in the room? I've got more on the cards.
Can I just say one thing more about oxygen? Sorry,
Yeah.
I know it was the previous question, but so my name's Andy Williams, the Chief Executive of the HSCIC, and on the question of security, so there were two reasons why, and I'd like to emphasise this is a prototype, and there were two reasons why we entered into it. One was to look at the actual information that you could deliver from some of the central systems from that point of view. But at least as important was, given some of the security concerns that people have, in fact rightly so, about mobile devices, could we put a security layer that involved also the use of the NHS smart card and three-way authentication? Could we put that into an app in a way that we felt was secure enough for the sorts of uses that we were putting it to, i.e. access to sensitive medical information? So a very, very strong part of the prototype and examining the usage of it is to test whether, in fact, that security, without going into the details of it, and we think it's pretty secure, whether or not that security is sufficient.
Great, thank you. Right, another question at the back here. So
I'll stand up because I'm right at the back. My name's Paul Raddin. I'm an involvement volunteer and a mental health service user from Nottinghamshire. I want to ask particularly about the evaluation of digital apps. And what I want to ask about is if I want to get an opinion that I value about mental health or about which apps to use, for instance, I would ask a fellow peer. I would ask somebody that's been through the things that I've been through. So I think that even when you get this accreditation process going, I think I'll still be visiting the app stores and prefer that and trust those more than an NHS accreditation system. So what I want to ask is, who is this work really being done for? Because I don't think it's for me and I don't think it's for my friends.
great, well thank you for that. And there's one of the questions on the cards is also on apps, so if you're happy I'll just throw that in now as well. So this is from the NRC UK, and they were asking about provider support around app use policy. So I think kind of two sides of the question there. One about how is this really reflecting what's valuable to people who are using the apps, and also the support that's going to be in place to help providers promote, presumably, the use of apps. So I'm looking at...
I can come back on that. So my name is Dimbad. I'm the Deputy Director for PHE, working on that particular work stream. So to directly answer the question regarding mental health apps, there's currently the process that's happening with NHS Choices is to promote these apps to citizens based on where people are landing on that website based on key search terms. So at the moment, if you typed in anxiety or stress, you'd land on a number of pages on the NHS Choices website, and from there they are promoting apps specific apps to help people with those conditions. That process of evaluating, is that an effective way to get those apps to people, is in a sense the carrot of going through endorsements. If you know that you've got a successful place for people to find them, that's the part of NHS Choices, the role that NHS Choices in the app space on that's going to do. And this has been considered in the next iteration of NHS Choices as well. The other work we're doing is working directly with Apple and Google and Microsoft with their iTunes, Google Play stores. They're very interested in an endorsement process to help them differentiate good apps from bad apps. So we realise the process itself isn't necessarily going to give apps to people. We need to work with the various places where apps are going to be findable, be that on Guard, be that on NHS Choices, and be that on the various app stores, and make sure the endorsement process allows for some differentiation between good and bad apps.
Can I add to this as well? I think what we're trying to do, as Dermot explained in our presentation early on, is that there are different stages to the assessment. And I think we're trying to bring different perspective on apps as well through those different stages. So while some more technical aspects might be managed through the self-assessment stage, looking at the security standards and stuff like that, there is this, for example, crowdsourcing and community evaluation stage that we have in the plan, which would bring the likes of your, your users and the people who have actually been using or commissioning those services locally to have an opinion. And then we might have then the view of the academics and the researchers who are sort of checking for the effectiveness and utility of these apps. Do they actually work? So it's about blending those aspects together.
Right, thank you. And on the question that was about supporting providers in how they're promoting the use of apps.
It's a very good point. I think it's providers and people who would recommend the apps as well. And I think that's a fair challenge we've got through the consultations that we've had. Is even if we had the perfect assessment framework and we could chunk out all the great apps out there, is how is it going to change the behaviour of both commissioners and people who prescribe apps, and do they have the time, even sort of GPs or the pharmacists, to go and use those apps? And so we have to think about that end as well, and what sort of systems do we need to put in place to help people use them and recommend them. So we are thinking about that.
Right. Good. Okay. I've got more questions on the cards, but another one from the floor. Great, thank you.
Hello, my name is Margaret Oates and I work as part of the mental health policy team in NHS England. We've heard a lot this morning about data flows across the NHS and the improvements that have been made, which is really great. But working in mental health often, or most of the time, means effective working across partnerships, whether that be across social care, schools, especially when working with young people with mental health problems. And we do know that there are immense challenges in doing that, but in order to get the right outcomes for the patients that we work in, we have to do that. So I wondered, had the board got any vision or timelines, plans around how we make that effective working and sharing of information across those important partnerships, how they will make that work in the future?
Great, good question. And there's another one on one of the cards that's similar. So just to throw that in again from the NRC UK. And this asks about the cultural barriers to sharing data across providers. So maybe if in the response, I'm not sure who's going to give that, you could perhaps talk both about just making it happen, kind of physically making it possible, but actually the cultural barriers around data sharing. Is that Tim, are you?
I hesitate because I think this is such a fundamental question, and I think everyone would have a really important view. But I mean, at the very heart of what we've been talking about in various ways today is this concept of shared digital standards, locally implemented, supported by national organisations where that's appropriate, cross-system organisations, local government, social care, NHS, and without the kind of communal collaboration, whether that's in mental health or in any other service, existing on the ground, the leadership that is across the system to implement those standards, we won't achieve very much at all. So what you're raising is an absolutely critical issue, and what we have to be alive to, just picking up on Una's point, is to be, as as a national information board, strategically flexible to learn as we go along, because I think one of the mistakes we could make, which we have to be very alive to, is not understanding perfectly at all what those cultural challenges really are on the ground, and needing to adapt our approach as we discover them in order to support local health and care leaders tackle them. So I think we just need to. I'm sort of expressing profound agreement with your point, and I think there are so many different perspectives that members of this board could approach that from. But making sure we are constantly keeping ourselves honest about the supporting the local cultural challenge, I think, is a really, really important issue for us.
So, yeah, it would be good some other perspectives then from members of the board.
Could I suggest that we truly co-produce it, and we ask the patient, and I ask the client, because I think there's some sharing that will come as a surprise to people. So if somebody comes to me as a geriatrician and I say, oh, I'm going to share your information with the police, that would be a complete surprise. But if or education or something on some of the other sectors, but if I asked and I had a good reason, the individual might say, that's a very sensible suggestion, yes, no problem at all. So one of the things that I think we can diffuse the organisational barriers with is actually talking to the individuals and getting the individuals concerned to work with us on specific issues. And generally, you find very strange things happen. I share all my letters with all my older patients, and one came in the other day and said, you've saved me 30 quid on getting a GP to sign a housing form. I sent you a letter, Prof, and because you're a Prof, they've put me higher up the list. Which was great. But the key thing is he made that decision, and he made that decision for himself and with consent. And I would just suggest to you that we can break down a lot of barriers by bringing the client or patient inside the sharing agenda.
Great, thank you. Other perspectives, I mean, particularly from clinical points of view, anything anybody would like to add? Oh, right, okay, thank you.
Thanks. It seems to me this links back to the question about the trustworthiness of apps. I mean, how do we demonstrate that we're trustworthy enough to receive people's confidential data? And there are lots of good examples across the country of the work that's gone on across the organisational barriers that have just been raised, social and healthcare and so on, because people have worked really hard to demonstrate to the other party that they're trustworthy with the data. I should have started this by saying I'm the National Data Guardian, so it's something I think about day in, day out. And as Martin has just said, we have to ask the patient, ask the service user, what is it that they want? And back to the colleague who raised the question about the app, I can understand at the moment you might have more confidence in your fellow users' views of apps, but I think as we demonstrate that parts of the system are trustworthy, in this instance the app, that will get known amongst the patients who have that particular problem. The example I often quote is people who have a problem with their kidneys. They've developed a really healthy network in which they share information, not just amongst the patients, but also with those doctors who treat people with kidney problems. And that demonstrates how when people have confidence that this is a group that they can trust, then they share things without thinking about it. And that's what I think we have to develop across different sections of the public who have particular conditions with the professionals, and we have to listen to you telling us what the problems are in trusting us. So it's all part of the same debate.
Thank you, thank you. Would you like to...
Hi, I'm Linda Thomas here from Macmillan, but actually representing all the charities that work in health. So I guess I just wanted to pick up the issue about sharing data. And for me, there is something, I think we do need to acknowledge that there is a massive issue in this country with people not realising what happens to their data. And I think it doesn't really matter what we do with it in health to a certain extent, because we will be tainted by anything that is happening in any other areas of what's going on. And I mean, at the moment, we in the charity sector are under quite a lot of attack at the moment around what we do with donors' data, for example, which is leading to huge amounts of mistrust. And I think we have to keep telling the story of the benefits of sharing data and why you want to do it, because especially, I think, for older members of the population, it is difficult. And what does happen to that data does actually feel... It's quite difficult to explain sometimes, and it's a really complicated story. But if you say this is why we need to do it, I think people do understand it, because it is open to such a lot of misinterpretation, both by the media and also by people when they don't really understand what you do with it. So.
Great, thank you. I've got other questions, but again, if there's anyone in the room who maybe doesn't actually have a question but has something more that they would like to share in terms of their experience, expectations from the information strategy, please do kind of put your hand up. Or okay, I'll carry on with these questions. But so we've just had one in, I guess, on Twitter from Matt Bull, which is asking about whether the NIB is thinking enough about the need and the opportunity to use location data. He goes on to say the NHS number gives us the who, but if we can link that with the address, we get the where. And I guess by understanding some of the things around people's locations, where they're living and so on, that gives us potential insight into other aspects of their sort of health behaviours, health opportunities. So is anybody able to answer that question about whether we're starting to look at how we can use location data?
It's a tricky one. I mean, again, I think everyone will have an angle on it, but it was very interesting yesterday. I was talking to one of the many great entrepreneurs out there who was wondering why we don't, with clinical audit, the fact that we don't use location data particularly well does mean we can't, for example, relate weather to outbreaks of particular conditions, and actually weather has a huge impact on incidence of different types of illness. And so this one simple... So I think, I mean, inherently within all the work that Beverly and colleagues are doing on Domain 1 and development of NHS.uk and so on, obviously what we're really trying to do is create a platform which others can innovate on, and they can bring their apps and other digital tools and services. And of course they are undoubtedly going to be using sort of location data and so on in that context. But it's a good point. I don't know if Beverly wants to add anything to that.
We haven't looked explicitly at location data. We're more interested really in resolving some of the requirements that the public are telling us they need around preferences. So being able to let us know how they like to be what they like to be called, what personal information about them. So we haven't homed in on location, but I think Tim's point about creating a platform that allows local health economies and the public to develop on an ongoing basis would open up the opportunity for that.
From a secondary uses perspective, sorry for the dramatic exit earlier, by the way. We use it. We use location often as a proxy for social deprivation. So there's something called the index of multiple deprivation, which sort of relates back to somebody's postcode, and that's a way of making sure that the NHS is treating all different groups across society equally. But I think the person on Twitter is absolutely right. There are huge opportunities for doing slightly more granular data. I'm actually going to bring Alex in, if that's all right, Alex. We had a conversation, didn't we, the day before yesterday about some data that I think was O2 hold, and quite amazing opportunities potentially to track people, how they come into hospital on public transport and so forth.
Yeah, I was going to come in, Gareth. No, it's seamless. I mean, I think members of the board, all the large mobile phone providers are starting to work with health institutions, and I was at a conference in Salford where O2 happened to be presenting, but they're not the only people who are doing. The fact is that apparently we are never more than a metre away from our mobile phone at all times of the day and night. So they're able to show hospitals the entrances and exits that people use, is that they might have doors in the wrong place. They're able to kind of say these are the buses people are getting to hospital. They're able, perhaps you could everyone gets off this bus and walks a mile. Perhaps you could talk to the local transport people about, extending that bus route, etc., etc. So I think, I would say I don't work for any of the mobile phone providers, but they're probably the people that I would suggest members of the board talk to about how to kind of integrate that more.
Right. Okay. Well, we've got is the question related or?
Related to the issue of
location.
Not location, no, but use of data.
All right. Well,
just quickly on location. I think for me this resonates a bit with some of the points I was making at the end of my sort of session today, which is some of the responses have been about how can we, in a sort of planned and controlled ways, better use locational data to understand patient movements, understand patient needs, understand infections, diseases, and so on and so forth. But of course, that's just a little part of it. I mean, you can imagine a world where the kind of the Tinder sort of Flickr, whatever, sort of approaches, and I'm just in case my wife's watching, obviously, I'm told, obviously you can very, very quickly find out somebody within 2 kilometres who shares all kinds of characteristics with you. Now, this emergence of multi-online disease communities, the ability to very, very quickly, if people choose to share their data, find out all kinds of people or share all kinds of things about each other, is going to face us. And I think the role of the National Information Board is being set up to try and understand some of these big social, technological changes, the way they're detonating around us, and what that's going to mean for health and care services. So I think our response needs to be not just a sort of controlled and planned one about how can we use geographical data, for ourselves, but also understand what social changes are going on that technology of this type enables. How is it going to change the way in which people understand, how they organise, how they share health data, how they identify with each other, how they agitate, propagandise, even infect, and what's that? What are we going to need to do in response? Because so many of these things are just immensely disruptive, and they happen outside the health and social system, but they then rain on us, and we need to have a mechanism to think about that.
Right. Okay. Well, thanks for that question on location, because that's probably a lot of discussion. But so, last question, I think, over here.
Hi, my name's Peter. I run an interoperability product in Hampshire. My question really is around the information governance issue and issues that we have, and around the sort of what I would regard as the sort of professionalisation of information governance and the effect that that's had in taking away the judgment of individual clinical professionals in understanding whether they should have a use of that data, and making their own minds up about what they need to see and what they need to what they will not need to see, and giving that judgment back to individual clinical professionals, doctors, nurses, and also care professionals, to make their own judgments about what the information governance rules should be as they apply to them.
Okay, thank you.
Yeah. I perhaps could say a word or two about, I absolutely agree with you, and it's one of the things when we reviewed information governance 2 or 3 years ago, the loss of confidence that clinicians and other professionals have in the system for how they can legally and appropriately share information was very striking. And I think it's partly that the advancing rapidity of change of technology has made many of us who are not techie experts quite nervous about the power, I suppose, the risk of sharing that's inappropriate. But it's also the fact that in the system, the health and care system, we haven't ensured that our staff, and this is back to the leadership questions that Andy and Nikki highlighted earlier, we haven't made sure that after the initial training that people have in the service, when we have the IG toolkit, with its limitations, but still it's something, we haven't made sure that staff becoming more senior have further training, supervision on some of the more complex aspects of information governance. The Caldecott Guardians try and do quite a lot of this, but they're not always well supported in their provider units and so on. So I think one of the opportunities that Secretary of State gave us yesterday in saying there needs to be a review of what the standard is in terms of how information is safeguarded and used across the system is actually a time when we can remind people that, yes, they do have some training, they may need more, but actually there's a lot that's there already, and giving people the confidence to use it, which is something about how is that developed within the service and made clear in all professions that they have lots of skills, but they just need to remind themselves of where the risks are and how to make judgments about those. Sorry, it was a long answer, but I think there's a lot there that does need to have further work done on it.
Right. Okay, well, thank you very much, and I think we've come to the end of our time now. So thank you, people in the room, for the questions. Thank you for the people who are following on Twitter and so on for their questions, and to board members for the answers. I'll hand back to Tim, I think, to close, or...
Well, Joe, thank you so much for facilitating that. I thought that was a really rich and helpful discussion. So thank you all very much indeed. It's been a really long meeting, but I hope you'll agree a really productive and useful one. Thank you all very much indeed.